All right, good morning, everyone. I'm gonna give everyone a minute to hop on here and we will get started shortly. This is our second annual Black Maternal Health Workshop during Black Maternal Health Week. It happens every year, April 11th through the 17th. And we are going to dive right into how we can improve our birth outcomes. So come on in, join in. I'm gonna give everyone a second to hop on here and we'll get started with the program shortly. Welcome. Thank you for joining. Good morning, everyone. Welcome. I'm just giving a minute for everyone to hop on in. Good morning. Again, it's our second annual Black Maternal Health Week workshop on improving birth outcomes. We are very excited about the topics today. We have some very great speakers here that's going to touch on some great things that will help us take better care of our moms so we can have better birth outcomes and healthier pregnancies and healthier babies. So welcome. Good morning, everyone, for joining. We'll be starting shortly, or thank you, everyone, for joining. We're starting shortly. And welcome. Happy Black Maternal Health Week, everyone. So while I'm waiting for everyone to get on today, we are going to be addressing three things, all right? So we're going to talk about access to doula care. We have some wonderful, wonderful women here today that's going to speak on the doula network. We also have a presentation from Count the Kicks. Megan AuCutt is coming on today. And if you all are not familiar with Count the Kicks is, it was a worldwide campaign that they did, launched through Department of Health with Healthy Birthday. And it basically, they have an app, it helps you count your kicks, and we want to promote fetal kick count. So we want to be able to talk to you all about that today. We also is going to have a presentation on lowering C-section rates. And then we have Dr. Sasha Davidson, who will be on later today. She has her own perinatal office here, right here in Fort Lauderdale, and she's going to come on and speak on that topic. So in just a few minutes, we'll be getting started. So again, good morning, welcome. We'll be starting soon. Thank you for joining us. Grand Rising, Ms. Tara. Welcome. Thank you for joining us today. Good morning to everyone in the chat. Very excited about today. We have some great information that we are going to share. So I hope you all are taking notes. We just want to be able to better assist our moms and our families. We all do great work in this community, and these topics will help us better assist these families and help improve the birth outcome. So I'm very excited about today. And I'm actually going to get ready to get the ball rolling. Let's get this down here. All right, so our first presenter is Esther Mccann. Now we're going to have the doula network, and they're going to speak individually and then as a group. Okay, so I'm going to start with Esther Mccann. Esther is the founder and CEO of Metro Mommy Agency. I believe it's located in Miami, but she's also part of the doula network and a doula here in Broward in Miami. So I'm going to go on and bring Esther on. And Esther is going to start with our first presentation of the day. So as Esther joins us, here we go. Good morning, Esther. Welcome.
Good morning, everyone. Can everyone hear me okay?
Everyone can hear. So I want to again thank you again for joining us. So now I'm going to pull up your presentation. Yes, ma'am.
Awesome.
Okay. All right, so can everyone see that?
Awesome.
Esther, can you see it?
Yes, I can. Thank you so much for doing that.
All right,
Fantastic.
Esther, go on and take it away.
All right, everyone. Welcome. My name is Esther Mccann. I'm the owner of Metro Mommy Agency, and I am extremely excited to be here today and join you all in this conversation. I'm actually really honored to just be a part of what's going on here. So, but first, I just want to focus in on why I know I'm here, and we'll start with our next slide. So my mission here is really something that has sprung from just my personal experience as a mom. I realized that being a mother, becoming someone who can influence not only small children that I'm tasked to raise and to rear, means that indirectly, I might actually be influencing other people. And so this has been infused into my mission from the inception of my business 7 years ago. And that is to influence, enlighten, and serve women with support and education to navigate through their journey into motherhood and become healthy contributors to the wellness of their society. So I'm sure without even seeing all of the participants here today, if you are a mom, chances are you are contributing to the wellness of your society. So, of course, that society starts at home. But I know for a fact that if you're on here today and you care about what we're talking about today, when it comes to Black Maternal Health Week, you are actually part of this mission. So thank you for being here. Next slide. My vision altogether also stems from what I've been seeing, which is lots of birth disparities. And I'm sure this is also why Black Maternal Health Week has to happen, has to exist, unfortunately. And it's because we have so many disparities. So my vision is that we do have communities where these birth disparities are eliminated as women are fully equipped for birth and beyond. So beyond that birth, getting that family to thrive is really important so that they can build healthy families with confidence. And we all know when you don't have confidence in an area, you struggle. And so this is something that I am aiming to do. Next slide. So a little bit about myself. I mentioned I have 4 sons. I actually homeschool. I've been a certified birth doula for some time. I actually certified with Common Sense out of Orlando. And I'm also a postpartum doula. So I get to see a lot of the needs that our families have at home. And of course, aside from sleep, there are some other systemic issues that come up. I'm also a hypnobirthing childbirth educator trained by the Vivian Keeler out at Amazing Births and Beyond, who's currently now the president. So we have, local certification agencies here in South Florida, which I'm really happy about. And like I mentioned before, as a lactation counselor, I do get to troubleshoot quite a bit with, breastfeeding families and help them be more successful earlier on. I actually am the co-chair for the Healthy Baby Task Force, which is part of the consortium for a Healthier Miami-Dade. So if you're ever in the area or serve families in the area, we do meet. We're actually meeting on Friday if you're interested in participating in that. I am a contributor for the Miami Mom Collective. And so we use different mediums, right, to educate. And I found that through blogging, this is one way that I can educate folks. And I have a current blog that was posted this week for Black Maternal Health that you're more than welcome to check out. So my connection to Healthy Start is through my work as the Education and Communications Coordinator for the Jasmine Project, which is located here in Miami-Dade County, where they provide pretty much wraparound services for pregnant families in Miami Gardens, Opa-locka, North Miami, some parts of North Miami Beach as well. And I am also the founder of a mentorship program. So I mentor new doulas, folks who are interested in being a part of this work. And I also do mentorship with a local nonprofit, Southern Birth Justice Network. So if you are following Black Maternal Health Week, you know Black Mamas Matter Alliance is associated with starting this whole movement. And our local connection to Black Mamas Matter is Southern Birth Justice Network. I'm known as just being a peer mommy mentor coach, happy to support families, encourage families, and I'm a networking queen. That's my self-acclaimed title. Next slide, please. So why are we here? We're here because you can fill in this blank with practically any location, right? Or most locations in our country, in our state, and even in our county. And this would be true. And that's an unfortunate reality. But this is why the work that we do is so important. Next slide. So some of the ways that I have been able to try to tackle this has been through these 5 keys. What I have found to be really integral and what I've seen as the common denominator or the common factor to why I can have so many families experience, natural birth or vaginal deliveries with a lot of success are these 5 keys. Number 1 is preparation. I spend a lot of time in preparation, and we'll talk a little bit more about that in detail. Number 2 is prevention. I think about looking ahead at what might be what we call red flags. And that even starts from the first time a family contacts me in a consultation. I can pick up on those things in a 5-minute, 7-minute conversation and be able to identify that maybe they might be walking into something a little dangerous, choosing a particular setting, choosing a particular doctor who doesn't have, a very good rapport among birth professionals as being supportive of physiological birth. Thirdly is patience, right? So I have to have a lot of that if I have 4 kids and homeschool, but you also have to have a lot of patience for physiological birth to happen in a laboring situation, right? And so we as providers need to also be patient with our different learning curves that our clients have to adjust to, right? So maybe you're the first person that's telling this person to eat healthier. You have to be patient with that process, right? There's a reason why we have January 1st, everyone's hitting and trying to hit all of these resolutions, but they need to readdress whatever resolutions they haven't been hitting by March, right? So we have to be patient when we're working with our families. Fourthly, we have to make sure that practice is involved. So practicing whatever those techniques and the tools and the coping measures and whatever mindset changes that you are encouraging them to do, they need to be reinforced with practice. As positive reinforcement happens, as you also encourage them, as long as you also keep them accountable, you're able to better support that family. And lastly, parent. Parent in that full sense of the word, right? Really make sure that these families are ready to parent their children, ready to be present and actively involved, ready to not only care for themselves, but care for their children at an optimal level. Right. And so I see a lot of this in the postpartum period where families are struggling, they don't have support systems, et cetera. And so we'll move on in the next slide or so to see more about that. Next slide. So I like to think about preparing for pregnancy kind of like in a timeline. And based on wherever you're at, that determines what you should be doing. So preconception, and you'll see some families that I've served, we talk about these particular things, excuse me. And preconception can also be something to consider when you think about interconception care. So in between pregnancies, what are we doing here, right? To ensure that folks are not repeating the same mistakes, right, that they might have made on a previous birth, right? And so this is where, unfortunately, I get folks coming to me saying, I don't know how to have a natural birth because, unfortunately, they did not choose wisely. And they didn't think about what were the implications on why the birth went the way that it did. So giving them time to process is really important. Preconception. Also, we know when families are healthier physically and they're eating healthier, they can also just drastically reduce a lot of risk and complications. So I connect them to people like personal trainers and dietitians if they're working with me, and I'm picking up on flags that they don't have a very healthy eating habit or practice or an active lifestyle. Preparing mentally is also important. So I do provide mental health support. I have about 5 Black female mental health therapists that I connect my clients to, and I allow them to interview and choose them so that they can make the choice to get prepared before the birth and also after birth as well, to kind of follow up and check in postpartum period. And then planning the pregnancy. So discussing it not only with the expectant family, the partner, but also the extended family as well, right? Because those are the folks who end up becoming a part of the village, right? Next slide. And so these are a couple of my Black mamas that I've been serving. The one on the left is actually a second-time surrogate family. She is doing this to literally support another family that cannot have a baby. And I've been able to walk with her throughout the whole entire process and that first day was the first sticky thought day, where we're hoping that everything went well with the implantation. And then the second picture on the right is the family I'm currently serving. She's actually on call. And the other woman in the picture is her good friend. And I invited her to be a part of our prenatal discussion to provide education. Next slide. So once conception happens, there's this other timeline that you want to pay attention to. And so as a provider, we should be definitely assessing their current health status and making sure within the first trimester that they're getting prenatal care. So that's what I would do. I'm getting calls at 6 weeks. Hey, I'm pregnant. 8 weeks. Hey, I'm pregnant. And I'm giving them guidance on getting prenatal care and advising them to seek out a healthcare provider as soon as possible, right? Because we want to avoid getting late prenatal care in the second trimester, right? And then in the second trimester, contrary to popular belief, we don't want to wait too late for childbirth education. And we also don't want to wait too late when it comes to breastfeeding. So I think that the earlier you can introduce those topics, the better, right? The more likely it'll start to stick, the more likely they'll be interested and being able to, move forward with that. And then the third trimester, you want to make sure you're planning for that postpartum period, right? So I don't want families planning too late, 36 weeks and beyond, right? Because we also know, especially with our Black families, we have sometimes higher preterm labor risks and things of that nature. And that's a little too late to think about, what am I going to do in the postpartum period? Who's going to be here to support me? So guidance on who those people are, giving them expectations, identifying what their roles should be, right? Not just what they want to do. Because you can have a family member who wants to do X, Y, and Z, but it causes anxiety in that mother and it stresses her out, right? So what we want is for that situation to be tailored to what that family needs. And then lastly, the birth. Again, I am going to always stand by a physiological birth because we know that's best practice. We know that aside from special circumstances where interventions are necessary, I would say that this is one of the ways that we've been able to attain really good birth outcomes. Next slide. So the other reason why I brought that up was because when it comes to breastfeeding, that's also something that I definitely want to promote and make sure you all are aware that that is really also helpful in the postpartum period to help that family heal, help that mother's womb heal, and also help with reducing things like hemorrhaging and excess bleeding and things of that nature in the immediate postpartum period. So this is just a slide just demonstrating and showing that I can teach about things like using our 5 senses when it comes to breastfeeding. And so I encourage you to check out Live Healthy Miami Gardens for more content because we've been posting for several years now. So I'm really excited about that. Next slide. So also as a doula, sometimes we get these random text messages based on our impact and what we've been able to do. And what I've been really grateful for is that with the education, When you have students like this one, she was a really good student, took great notes during our sessions. And our sessions actually look like prenatal visits, 1 to 2 of them prior to the birth, sometimes as much as 3 prior to the birth. And we spend time in childbirth education. And this is just a comment from one of my recent clients. She had 2 babies with me. And she's just, commenting how important preparation is to her and the impact of it. And the baby on the side is just a doll that I've been using that helps actually a father during it was a breastfeeding class, really finally get a feel and understand, wow, this is my role. This is the role that I have to play in holding this baby, supporting this baby. And it was just his first reality check that, yeah, they're really having a baby. So I do work with fathers as well. Next slide. This is me at a Tree of Life community baby shower. So hosting community baby showers, attending community baby showers, but more importantly, tabling is another way that we as providers can promote better birth outcomes in our communities. Don't be afraid to put yourself out there. I've made some amazing connections, networking, again, introducing myself to fathers who are present, to people who never even knew what a doula was. So I've been doing this for quite some time, and this is how we can advocate for things like doula support and breastfeeding support and provide access to families for this. Next slide. So the village, right? So for those who are providers on the call, I'm not sure where your place is, but you do need to find a way to fit into this village and make sure that they know that if they don't have that consistent support from a family member or a friend or a healthcare provider, they can reach out to doulas for support. And I'm sure we have case managers or insurance folks on the line. You all are a very important point of contact. And those referrals are really crucial for our families. So I hope that in seeing this visual, you can see it's not just meant for these folks to kind of like do things on their own, right? We really want them to know there's lots of options for them in terms of support. Next slide. This is just me supporting a family. Sometimes, during labor, we have to get, low and dirty and on the ground with them. And this is actually a client who actually visited, and I'm sure you all remember this back when Bahamas had the whole hurricane, right? This was one of those clients who came through and came by, unable to support herself financially, living with family members, friends, we as Black women, we go through a lot. We live in a lot of different, circumstances and living situations, but that does not exclude someone from getting doula support. And so myself and 2 other doula mentees of mine, we just tag teamed and, supported her during her stay here so she could have support. Next slide. So again, just some more information and just reasons why we do this to expand our reach. And I do want to extend an invite to those who also serve folks in Miami. Breastfeed Miami is something that I'm a part of with the Children's Movement, FIU, Healthy Start, the Jasmine Project, DOH. We all have gathered together to increase awareness of breastfeeding, but also to provide professional development. So for those who are needing any professional development, CEUs and things of that nature, and want to just connect with other providers, definitely reach out as well to Breastfeed Miami. Next slide. Another way to promote and encourage more healthier birth outcomes is to get on social media. So I was able to connect with Rachel Turgeman on a Facebook Live event. I've done 2 with her, and between those 2, I think we've reached about 17,000 people. So these are different ways that we can actually promote healthier birth outcomes, make it a norm, make it standard for folks to know about doulas and what we can do. Next slide. And lastly, I just want to promote just one more event that's happening this week for Black Maternal Health Week with my chiropractor, Walker Chiropractic. And this is an all Black chiropractic center, and we'll be talking about Black maternal health this coming Saturday, if you're interested, at their location in Miramar. Next slide. So what are some 5 takeaways for today? Talk with the doula, please. Don't be shy. I'm happy to chat with you. Share your events and your resources. We love doing that, sharing that stuff. So if you have an event that you're hosting or want to promote that involves supporting families, pregnant families, postpartum families, families with children under 5, let us know. We're happy to share. Connect and attend our events. Like when we host them, come through. That's also a way we can promote better birth outcomes and share resources that we share as well. So for example, on social media, if you are kind of like stuck sometimes with promoting items and things of that nature, I would definitely encourage you to go ahead and make your own material. But if you don't want to make your own material, just repost what we have and it's fine. And that's another way that we can share information. I can't tell you how many people have reached out to me because of something that was shared by another doula, and they thought of me because they know I'm local. And that's how this all goes, And lastly, keep funding doula supported initiatives. I think that's really important. I did receive a grant that I definitely want to talk more about at another time and date. And that is one way that we're going to also increase access to doula services. So I'm really excited about that. Next slide. And let's connect. So here's my contact information if you ever want to learn a little bit more. I think my time is up, but it's been a pleasure chatting with you all today. And I just want to encourage you to keep doing the great work that you're doing as we improve birth outcomes together. Thank you.
All right, Esther, thank you so much. That was amazing and such rich information. I'm just pulling this down. I'm not sure where you just went off to if I lost you, but there we go. Sometimes there's a bit of delay, but thank you so much. So let's see here. I want some crazy things going on. It's always fun when it's live, right? So I'm just going to roll with the punches here. Okay, so everyone, Esther is going to hang around in the background for a little bit while we bring on the next 2 presenters, and that way we'll hold questions to the end of the doula segment. So let me I want to take Esther down as well. And then we're going to bring in our next 2 hosts. So there we go. Let me just do this. Esther, you're just going to kick it on the side. So I'll be back with you soon. All right, here we go. Okay. Let's do this too. All right, so next up, I'm going to bring on Elizabeth Simmons. She's the founder and CEO of the Doula Network. And I also have Briana Betton. She's the Doula Onboarding and Technical Assistance Coordinator. So we're going to bring both of them on and they will take over for the next portion. So here we go to Elizabeth. She's coming on and it takes a little second to kick over. And I'm going to look for Briana. Okay, Briana Betton, here we go. Good morning. Okay, let's put that here too.
Good morning.
Thank you so much for joining us. And here we have Briana Betton.
We're honored to be here. But before we begin, we just need to take like 1 second to give like enormous props and honor to Esther. Esther, that presentation was unbelievable. I'm very lucky, Briana too. We get to work with Esther. We already knew how amazing she was and how much work she did. It's been really exciting. Esther is all things doula. Just a quick story. We were doing a training not that long ago, just at the end of February with Broward Healthy Start with Samantha Silver, with the team that's hosting this today. And who walks into the room to support us is Esther. She's just like, hey, I'm here. Can I help? And ends up spending the whole day mentoring doulas, teaching doulas how to support birth. And it's great. So thanks, Esther. I'm so excited. Oh, there she is. Hi. So, but we'll get started. Briana and I have a quick little presentation about the Doula Network. Basically, Briana, can you share or do you want me to share?
I can share, I hope.
Awesome. Always have to get all that technical stuff figured out. So I'm going to start off and then kick it to Briana. So we'll be here together for all of you, and feel free to put any questions or comments in the chat and we'll definitely get to them at the end. So I'm Elizabeth Simmons. As said, I'm the founder and CEO of the Doula Network. But really the most important thing to me is that I'm a birth doula. In all of that, that's really my claim, that what I like to claim mostly. So just for a quick background, the Doula Network was founded in 2019 as a response to supporting doulas in Florida get reimbursed by Medicaid. As many of you probably know on the call, the Medicaid benefit for doulas actually went into effect at the beginning of 2019, but it was really underutilized because we just didn't know how to do it. And so I have a lot of aspects of my personality, but one of them is that I'm very determined and I sort of really enjoy insurance and figuring it all out. So, you know, we came in to try to figure out how we could support doulas, because doulas like Esther and a lot of you on the call are already doing so much work. You're supporting your communities, you're supporting your families, you are that go-to person for your whole community. Right, somebody gets pregnant, everyone's like, do you know Esther? Have you talked to her? You know, you're already holding that huge pillar of support. And so what the Doula Network wants to do is be the support to you and support doulas so that doulas can do their best work and get reimbursed a living wage from Medicaid. So that's really why we started and why we're here. You can go to the next slide. So this is our mission and our vision. Really, our mission is to create this like foundational system of doula services, so that doula services are not seen as an outlier, as not seen as like an add-on to care, but really foundational. We know, and Esther pointed this out, that the Black maternal health crisis is really reaching, I mean, it has for decades and decades been an enormous problem. Black women are dying at 3 to 8 times the rate of white and Hispanic women. And sorry, my allergies are killing me today. But where was I? Oh, sorry, lost myself for a second. This is where live is hard. And really, we want to make sure that we're able to provide doula services that are culturally congruent, culturally resonant, and really are for the clients. And so that's what we want to do. And what I was thinking there for a second was just about how we know that the maternal care system is broken, and it's built on a foundation of systematic racism. And it's really hard to move those systems, but something we can move very quickly is bringing doulas into the fold. We can train and get doulas up and running and serving clients very quickly. And when we have amazingly skilled people like Esther in the community who can then support those doulas and mentor them, we can really impact those outcomes, which is awesome. And so then our vision is really that every person that wants it is going to have access to that care, that they can have the care of a doula and that it becomes the norm. So I'm going to kick it over to Briana to talk a little bit more about the Doula Network.
Yes, so good morning, everybody. Like it was said earlier, my name is Briana. I'm the Doula Outreach Coordinator over at the Doula Network, and I handle all things doula. And so a little bit about our network. We have 95 doulas in total in Florida, credentialed through our network, and we have 37 doulas specifically who support the Miami-Dade and Broward area. And we actually just did a training, like Elizabeth was mentioning, in February to support the fact that we need more doulas in that area and more doulas who speak Spanish and Haitian Creole to support the birthing people in that area. So a little bit about what our application process looks like is there's no fee to join. You just visit our website and you say, join the network. And then you will begin the process to become a covered provider with the doula network. And so the credentialing requirements are that you have a doula certification, you do a CPR first aid certification, a level 2 background screen, do a HIPAA compliance, and then it's optional to have professional liability insurance. We have our own liability insurance that covers you when you do, when you serve our clients. But if you are a private doula and you take clients outside of that, if you want to serve your family members, if you want to serve in other places in the community, you might want to just get the liability insurance. And the process is super easy. It's on like this platform, and I will be in constant communication with you if you fill out your application, and I'll make sure you get all the pieces together and help you get credentialed as fast as possible so you can start serving the clients. And like Elizabeth touched on earlier, we are really here to support doulas being doulas. And so we manage a lot of the administrative pieces so you can just focus on serving the clients. And so we get client referrals from healthcare providers, the health plan, community agencies, or sometimes moms will refer themselves to our services. Then we do our own internal intake process where we verify their insurance, make sure they're able and they qualify for Medicaid reimbursement of doula services. We educate them a little bit about what a doula is. And then we ask them, like, what are the most important pieces for whatever doula you get? Like, do you want your doula to look like you? Do you want your doula to speak the same language? Would you like your doula to have the same faith beliefs as you? And so because we know all the doulas in the network, we work really hard to connect the birthing people to the doula that they ideally would want. And then we support the doula throughout their care of the client. If they run into any issues, anything like that. We're all doulas. I guess I forgot to mention that I'm also a birth doula in our practice as well. And so like, should you go to the hospital and get into a pinch, we're there to support you, not only emotionally, but also practically, because we all know what it's like to be in the birth room and can give you suggestions if you're stuck. And then that last piece, it's with billing. We have different contracts with the health plan. And so we support with the filing of the claims. And we have our own software system where you just log what you do with the birthing person. And then when you're done, you just hit a quick button, submit, and then we're on to billing and we'll get you reimbursed as fast as we can. And so if there's anybody on the call who maybe wants a doula, or you can share this information out with anybody you meet who happens to be pregnant, you just visit our website and fill out our referral form, and then that'll get you in the system and you'll speak with that intake coordinator and start that matching process like I just discussed. And I will kick it back over to Elizabeth to talk about the data.
Ooh. So we love to share this data because it really is not the networks. It's the doulas. This is what the doulas have been able to do. We are the collector of the data. We can analyze it and pull the reports, but this is really what has happened. Now, as I mentioned with the network starting in the fall of 2019, our first match was like March 9th of 2021. So 2020. So in case anybody remembers, right, that was the COVID. So all of the care so far has been through COVID. And for those of you who are in South Florida, especially in Miami, you know what a struggle it has been to support clients getting into hospitals and all of that. So I say that because what you'll see here, there's two graphs. The smaller one is really all the clients that have been supported. And then the larger graph is those that had doula support. So those that were able to access and have the doula actually physically come into the room with them and be present at their birth. And so we just love to share the work that our doulas are doing. Our vaginal birth rate and our cesarean birth rate are right where the goals are for having those rates. We know that having a doula is really impacting those rates. I mean, you can look even within our own sample set. When a doula isn't present, the cesarean rate was almost 37%. when a doula was present, it was just under 24. So it's really like, that's remarkable to know that this is what a doula is doing. And Esther did such a beautiful job of explaining what doulas do and where they interact. And really, it's that continuous, intimate care. And it makes an enormous difference. When you're pregnant and you're in labor and you go into the hospital or even into a birth center, having somebody who's right there with you, looking at you in the eyes, who you've shared confidences with, that is there for you and your baby and your safety, is such an enormous weight off your shoulders and a way for you to really sink into the process. It's almost indescribable unless you've done it. Then you're like, oh yeah, that, it makes such a difference. And so that's what these numbers are reflecting. The primary cesarean rate is very low, and a really cool rate that we like to talk about is this NTSV. It's a little heady, but basically it means nulliparous, meaning it's her first baby. Term, the pregnant person got to 37 weeks. Singleton, it's just one, and vertex, the baby's head down. This is a really important rate for our communities, for Black maternal health, for all maternal health too, because if your first birth is vaginal, then your subsequent births are most likely going to be vaginal as well. And we know that the long-term consequences of repeat cesareans, there's so many impacts, there's so many health consequences that can come from that really, if we can start to change how birthing people are treated that first birth, where they're seen, they're heard, they're given comfort, they're honored, their faith beliefs are part of their process, all of those things, then we know we can impact not just future births, but Esther, I think you talked about like how they parent, how they show up for their families, right? All of that flows from here. So it's really, you can say that out loud, Esther, you can unmute yourself. We always welcome you in our experiences.
Yeah, no, that first birth is so important. We always talk about the primary cesarean, that first birth, so when I even think about what would qualify, what's a reason to refer a mom, is it her first time? Yeah. Refer her to a doula. So she can get it right the first time, because it's so sad to hear the story. Second, third, fourth time, they did not, they didn't use a doula the first time. And so, it's a struggle and it's hard to hear. So, yeah.
It is. And I think, Esther, that's a point of the work that we all do that I don't know if we've totally touched on yet, but is around that we do a lot of work around trauma. A lot of times if a first birth, or where you're not supported, where you're not seen, where like when you say no, they don't listen, things like that. That trauma, that's hard. It's deep in your body. And so as doulas, we really help. So if you've had a first birth that didn't go the way you wanted, it wasn't what you needed to have happen, that's a beautiful thing too about having a doula with your second or your third or your fourth, is that a doula can really help you look at that experience and kind of mine it for the gems that are there and for the wounds that are there, and help you process and get ready to birth this next baby in the way that you want to, because each birth is so unique. It is so different. And so it's a lot of the work that we do. Doula, if you can ask your doula, like, are you, that just made me think, like, trauma-informed care is something that a lot of us are trained in. We take classes in making sure that we really understand how to support birthing people in those intense moments of stress and anxiety, which can happen in a birth. So I wanted to share these numbers with you, mainly because it just makes me so ecstatic to see the impact that doulas are having in Florida right now on the maternal health crisis, the changes that are happening like today. And that pretty much, I'm assuming a lot of people on this call, everyone on this call is being a part of it. We were invited here today by Samantha Silver, who's part of Broward Healthy Start. We have to give her a shout out. And she helped to organize and launch a training at the end of February where 15 women became doulas, women who spoke Haitian Creole, who spoke Spanish, varied birth experiences, some who hadn't had kids, some that had quite a few kids. We even had a doula there who had been a client of the doula network before. So it was this amazing, magical thing. And So if you're on this call and you're thinking this doula thing sounds really cool, reach out to us, let us know, because there are opportunities where these trainings come up. We're trying to get funding so that it doesn't cost you anything to support these families, that you get to follow your passion. So let us know. We'd love to make sure you're on a list and see if we can't get you into a training. We have a couple coming up this summer, one in Jacksonville, one in Polk, and one over near Tallahassee. So exciting. Briana, back to you. Take it away.
All right. So just a little quick snippet about the accepted health plans that we take for clients: Aetna, Clear Health Alliance, Community Care Plan, Florida Community Care, Molina Healthcare, Simply Healthcare, United, and Levita. And for each one of these health plans, the reimbursement rate for doula services ranges in between $800 and $1,125. And it just kind of depends on where you are in Florida, depends on your reimbursement rate, but we've worked really hard to get a livable wage for each of the health plans that we contract with. And if there's not one on here, it's probably because they do not believe in reimbursing doulas at a fair wage. And that's something that's really important, not only to us understanding what it means to be a doula, but also understanding the labor and the work that it takes to be a doula. We really want you guys to feel supported physically, emotionally, but also financially, because this work is necessary, but it's also very difficult, and you deserve to be paid fairly. And like Elizabeth was saying, just stay connected. If you have more questions for us, if anything comes up after this presentation, here's our email addresses, and we'd love to just connect. And that is all we have.
Thanks, Briana, for leading the slides. And I know that Briana and I are here to chat anytime. I know Esther is too, and especially if you're in her region, you need to reach out. If you're down south, like you need to know Esther.
Yeah, and I would just say, as part of the doula network, I'm listed as an agency. So I am always looking for other doulas who want to work with my mentorship in mind through the doula network. So that is something that I do want to highlight there.
That's an awesome thing to highlight. Yeah, because working within an agency also provides you kind of like with another level of support, because then you have backups already built in, things like that. And so if you're curious about what is an agency, what's the difference, let us know. We're happy to talk about it with you, because everybody's kind of a different doula, how they like, it's personality, it's how you like to work. And so we really want to help you build the right support network around yourself so you can succeed, because it is an exhausting job. And we want to turn this into a career where you really can do this and be excited and connected to your community and providing those resources. So thanks everybody for having us. That was amazing. That's so fun.
Thank you so much for being on today, ladies. All this great information was amazing. I'm going to ask that anyone who has any questions for Elizabeth, Briana, or Esther to put it in the Q&A so we can get your questions answered. I've seen a few things in the chat that were coming up. It looks like they were trying to get some information. Sorry, I'm trying to catch it as it was coming. One in particular information. So let me see. I gotta navigate this. I see Esther put your information in the chat. If there's anyone on right now who has a question, please post them now so we can get you your answers while we are live. But as we wait to see if anything comes up, I just want to say thank you so much for all the great, rich information. And I think it's beautiful the way the doula network is expanding, especially in Broward. You know, the event we just did, that Samantha and you all worked together and got 15 more doulas in Miami and Broward to continue to add on, because the women need the support. And I hope that everyone that's on the call today that's working with expecting women and parents and families can now relay this information confidently or comfortably, and to be able to say, hey, I know how to get you some help, and let's connect you with someone. And also, I hope everyone take note of the healthcare plans that they listed that accept it, because I know a lot of times that's where moms get a little concerned about. It's like, how can I afford this? How can I add this on? So again, thank you so much. Okay, so Shanice Tullock asks, how would referral process work with clients under 18?
So it's just the same. You can go to the website and fill out the referral form. And that's it. So you just go to the website and say, like, submit a referral. And we ask our doulas a lot of questions about who they want to work with. So we often have doulas who kind of specialize or prefer working with like teen moms. And then we have some who prefer to work with like moms who are older. And so we'll make sure that the client gets matched with somebody who can truly understand their experience and support them. So, and if you want to talk more about referral process and things like that, just shoot Briana and I an email and we can set up a time to chat further. We can kind of go through it, walk you through it, all that kind of stuff. So.
Okay, and next Sheila is asking, can the presentation be sent over? I do have plans on sending out the recorded cloud, so you'll be able to have this information to be able to refer back to. So yes, and at least all the contact info with the health plans and such. So I don't know if that's also something maybe we could work out, Elizabeth, or Briana, or Esther, maybe we can send me something that I can also blast out that has the healthcare plans listed again. Or maybe that particular slide, or if you feel comfortable sharing the whole presentation, I can forward as well. So they have something to reference to when helping these families.
Yeah, for sure. We can get you a little like flyer, something to send out. Martha was asking about who qualifies for a doula. For all the health plans we work with besides United Healthcare, all clients qualify. It's open to anyone who has their Medicaid program and is pregnant. For United Healthcare, the client has to have a high risk diagnosis, but that can be any high risk diagnosis. So under 18 or under 21, over 34, those are high risk diagnoses. So we can support you in that. So you can always call and say, this is what's going on. Do you think they'll qualify? And we can check to make sure that they qualify. So
Christine is asking about undocumented clients. How would they assist them?
So we don't have Medicaid doesn't. So this is an expanded benefit with Medicaid. So it isn't covered by temporary or emergency Medicaid. So what we would do in that case is if you have somebody, you could talk to us and we would send it out to our doulas and see if there's anybody who does discounted births or sliding scale or free births. So we can see if we can help connect that client with the doula as well. So a lot of our doulas have that, or like Esther might know some new doulas who are looking to really gain experience, so we can connect that way. So there's a lot of different ways that we can help get that person connected.
Yeah, that's exactly what I was going to suggest.
Yeah. Oh, sorry, go Esther.
Yeah, that's exactly what I was going to say. So that mom from Bahamas, she's not from here, but we served her anyways because, every woman deserves a doula. So we will find someone to connect them to. I think it's really about the desire to have one, but also the understanding of the benefits of it, making sure that that's clear to that person so that they take advantage of the service, right? And really use the service. That's what we really want. We want to be used. We don't want to just have to show up to the birth and we don't know the client. We don't really, so we really want them to use the service. And yes, for Briana's question, high blood pressure, absolutely. I was at a prenatal with a client who had to monitor her blood pressure. And during the prenatal, we were able to see that, wait, you hadn't checked your blood pressure this morning. Check it now. And sure enough, 223 over 120 or something crazy like that. It was a sure sign for her to go to the hospital that night. We did not finish our prenatal because she had to go to the hospital. So absolutely, any of those signs and symptoms, we can assist with that, and actually gotten some additional training on that, on how to support those families, how to, help them test their own selves at home in between those appointments. But I personally do not provide clinical care, but definitely we are advocates for them to have their own autonomy and take care of themselves.
Okay, and I'm not sure if this, okay, so I have some questions over in the Q&A over here. Maria is on from Healthy Mothers, Healthy Babies, Broward, and she wants to know, is it possible to get a speaker to the baby shower to give the clients that information as well, how to receive or how to access the doula network and how to go about getting a doula.
Yeah, send us an email. We'll figure out getting somebody there. If you said it's May 7th, so we'll figure out.
So if you ladies can put your emails in the
is-
chat, I believe that Esther did, but still, and then someone, this is anonymous, I can't see, but it said, I may have missed this, but for Esther, what does doula mentorship entail? How do we get support in becoming a doula?
Absolutely. So definitely visit my website. There's a tab just for you. There's some freebies there. And what we would do is we would connect on the phone. We would chat, you'd send a resume. And there is paid doula mentorship at the moment, but there's also ways for you to get it supported financially for free. So that is what I'm offering at the moment. And right now is a really special time, right? Because everyone's talking about doulas, everybody's interested in funding doula programs. And so I'm actively looking for funding to expand the reach of my program and also to increase direct services locally. So yeah, I have some folks on here who are already part of the program. They'll be chatting with us all year long on this grant that we've acquired. So yeah.
And I think this was one more, I'm not sure if we covered it, but they want to know, I know we addressed as emergency Medicaid cover it, and if not, are they able to pay under a sliding fee scale according to their incomes?
Yeah, we have doulas, and Esther probably knows some doulas who take clients either sliding scale or donation based or even sometimes free. So we would just say, fill out, fill out the referral form, and you can let us know, hey, this client does not have, any kind of insurance, no coverage, is there anybody? And we can send it out to our doulas. We have an internal communication system that we can send it out through and just say, hey, is anybody up and available for doing this, or no, any doulas? They're, especially in Broward and Miami with the 15, I think it was 15, right? 15 doulas that trained that weekend. A lot of them are looking to learn more and to do more birth and to support more. And I'll tell you that just because a doula is new doesn't mean that they're not already amazing at their job, because really what doulas have to be is experts in the client. That's really what a doula is. A doula is an expert in you, and not necessarily an expert in like birth positions. They'll learn that, they'll figure it out, they'll get it, but really, they need to connect with you. So we will help you find somebody who can connect with you. And that's really the most important part of the process. So, yeah.
Okay. All right, well, again, ladies, thank you so much for all the great information. You have been so helpful. For anyone who has any further questions, I ask that you can post them in the chat, or you can send me an email, and we'll try to get you those questions answered at a later time, just for the sake of time. And there's one that came across here on the Q&A. United Healthcare no longer reimburses some hospitals in Broward. Will United Healthcare cover doula services for those hospitals?
They will, but the client might not want to go there, because then the client has to pay out of pocket, and a hospital is a lot more expensive than a doula. So yeah, I think that clients, we want to encourage clients to go to providers that have their insurance, because we don't want to expose anybody to a financial liability. But yeah, the doulas operate separate from than the medical care providers. So, the doulas can serve kind of independent, we serve independent of those providers. Does that make sense? Hopefully I answered that for you.
Yeah, okay, so that's it. We're good to go. So thank you again, ladies, so much. We greatly appreciate it here over at Healthy Start. And happy Black Maternal Health Week. Like I said, this is from April 11th through the 17th. And we hope to continue to build more doulas and continue with the support for these families. And you all do such great work, and we're just so grateful to have you today and to be able to share this great information to everybody that's on this call right now. So we're building more connections, and I'm sure you'll be hearing from a lot of them soon. So thank you so much again for joining, and until next time. Okay, you all, so we're going to move right along. And then next up we have, as I'm like pulling these down. Okay, so next up we have coming on is a presentation from Count the Kicks. Now, fetal kick count is very important for moms starting at 28 weeks. And we try to continue to promote this because there's a lot of things that, or stigmas out there that goes with fetal kick count or baby movements, and mom saying, oh, baby isn't moving because baby's too big now, or baby's running out of room, or maybe the baby is sleeping. And we just don't want moms to continue to associate that with their fetal movements. We want to make sure that these moms are counting their kicks at least twice a day, making sure that they have 10 fetal movements in a 2-hour period. So next up, I have coming on Megan from Healthy Birthday. I believe that she's actually the CEO and founder of, or no, I'm sorry, she is the director of programs for Healthy Birthday, and is over at Count the Kicks, and she's going to be able to give us this great information. So I'm going to bring on Megan AuCutt, and I'm going to see if she's going to correct me or not for this name, but we're going to welcome Megan on. And she's coming to talk to us about Count the Kicks, and she'll give us all the great information about the app and how to use it and how to promote this to our clients so we can continue to help improve these birth outcomes here in Broward County. Morning, Megan, how are you?
Good morning. I just was changing everything around. You did pronounce it right, so thank you so much. You're like the only person that ever does. So 10 out of 10 today for you. Thank you.
All right, Megan, perfect. Are you ready to take it away?
I am. Thanks so much for the intro. I'll go ahead and share my screen.
Okay, here we go. And I'm going to come off and here, oh, wait a minute. Did a little boo-boo. Okay, let's go back and fix this. You gotta love doing things live. So let's see, here we go. Okay. Uh-oh, did I lose her? Okay. Let's try this again. Sorry, everyone, just give me a second. I think we lost her. Let's get a minute to try to get her back on. There we go. Okay.
Sorry about that. I don't know what.
I was like, what happened?
I'm here. I'm just going to try and share my screen again.
Okay, let's try it out again.
All right.
All right, here we go. All right, Megan, take it away.
Thank you so much. All right. Hi, everybody. Thanks so much for having me today. I'm excited to be here. My name is Megan AuCutt. I'm the program director with Healthy Birthday, Count the Kicks. I am excited to be here and talk to you during this wonderful week. And I know that we'll continue these conversations past this week, which is really important as well. So Count the Kicks is an evidence-based stillbirth prevention education campaign due to a partnership with the Florida Department of Public Health. All of our materials and resources are completely free for you all. And I'll talk through that here in a little bit. So like I mentioned, I am the program director with Healthy Birthday. Healthy Birthday is the nonprofit organization that created Count the Kicks, which is that evidence-based stillbirth prevention education campaign. Here's my contact information. I'd love to hear from you. You guys are our boots in the ground. I'm based in Iowa. I have my space heater on today. It's cold, it's 36 degrees. So I love talking to you all in Florida because I know you're probably having much better weather than me. But because I'm in Iowa, I can't be on the ground there in Florida as much as I would much rather be there. I can't. So I look to you all to help share this message and share these tools that you're going to get today to be able to talk about fetal movement monitoring with your patients or clients. So just high level, what Count the Kicks is, it's that evidence-based stillbirth prevention education campaign. It's an early warning system for expectant parents. It educates birthing people on the importance of tracking fetal movement through the use of our mobile app, which we'll talk about here in a minute, or our paper charts. And one of the best things I love about this is it's empowering. It empowers expectant parents to speak up to providers if there's a concern. In Iowa, where the campaign was created, we've seen a 32% reduction in the number of stillbirth rates since 2008. So we're saving 1 in 3 at-risk babies from preventable stillbirth. And that's what we want to bring to Florida. That's why we're partnered with the Florida Department of Health. That's why we're partnered with Healthy Starts, just like you all, and doulas and midwives and OBGYNs and CBOs to make sure that we can implement this campaign like we've done in Iowa to see the same success. So just to make sure we're all on the same field with terminology. What we're talking today about is a stillbirth, which is the stillbirth is a loss of a baby after 20 weeks of pregnancy. And it's further classified as either early, late, or term. A miscarriage is usually defined as a loss of a baby before the 20th week of pregnancy. And then you have infant mortality, which is death of an infant before his or her first birthday. So they're born, they take a breath. On average, we lose around 22,000 infants every year in the United States. And then compared to stillbirth, we're losing around 23,500 babies every year to stillbirth in the United States. So what I really want you to take away from this slide is the fact that we're losing just as many babies to stillbirth as we are to infant mortality, and nobody's talking about it. We've got to talk about this, just like you talk about back to sleep, the importance of not smoking while pregnant around baby, the importance of taking folic acid and not drinking. We want to be talking about stillbirth and stillbirth prevention just as much, so we can get to a point where that number significantly decreases. So taking a closer look, especially at the race disparities that exist, 1 in 169 pregnancies ends in stillbirth. This is across the United States. For Black women, it's 1 in 96. Black women are 2 times, sometimes 3 times, depending on the state, more likely to experience a stillbirth over their white counterpart or neighbor or friend. Hispanic moms, Latinx moms, 1 in 199. Indigenous women, 1 in 138. White women, it's 1 in 204. Asian Pacific Islanders, 1 in 233. Again, it's just as prevalent as infant mortality. Families are 10 times more likely to lose a baby to stillbirth than to SIDS. So I took a look at the data specifically for Broward for you all, and then compared to the state of Florida. So this is 2020 data. You can see there that York County specifically, your stillbirth rate as a county is 7.5 deaths per 1,000 births. So compared to the state, which is 6.8. So you're slightly higher than the state total there for 2020. If we look at your Black stillbirth rate, it's 10.8 per 1,000 live births compared to the state, which is 10.3. For white, you can see right there, the Black rate is significantly higher than the white rate at 4.1. White for the state is 5.2 and Hispanic is 4.6 compared to 5.6. So on average, 174 babies are stillborn in Broward County alone every single year. On average for the state, around 1,511 babies are stillborn every year in Florida. So our goal is to see that 32% reduction like we've seen in Iowa and bring that to Florida. So if we did that, we could potentially save 484 babies from preventable stillbirth across the state. That would be 56 babies from preventable stillbirth in York County alone. So that's what we want to do. And so you keep hearing me throw out that 32% reduction. And what I want to just take a moment to share is that we were founded in 2008, which is when the campaign had a soft launch. And so you can see that teal dot there where it's the highest there on the graph. And so what we really want to do when we're looking at stillbirth numbers is we want to look not just year to year, but what the trend is. What is it, the 3-year and the 5-year averages? And so you can see we've had that downward trend since 2008. And public health officials have said there's nothing else going on in Iowa that would have made such a significant impact. It's not like every pregnant woman had doula care, which would be amazing, and we know would greatly impact stillbirth rate. It's not like smoking rates or obesity rates decreased. In fact, those actually increased, which are risk factors. So they've truly stated this is the only stillbirth prevention program that's happening that would have made such a big impact on the rate. And so this is what we want to see. From 2008 to 2018, there was that 32% reduction in the number of stillbirths. In the first 5 years of the campaign, we saw a 39% reduction of stillbirths among Black women. And so you can see we've had that trend. There are a couple outlier years like 2017, 2019, it looks like. So that's why we look at that trend overall. Those could have been, syphilis outbreak, infections, pandemics that we know have impacted stillbirth rates. But what we really like to see is that 2021 preliminary have continued to go back down. So that's really exciting. So what I really want to take a moment to share is, especially during Black Maternal Health Week, and our health equity coordinator, Stephanie Moody, who's fantastic and wonderful, couldn't be here today. So I'm here in her place. We do have a lot going on during this week, so be sure to check us out on Facebook and social media. She just hosted a great panel discussion of the state of the Black maternal health yesterday, and that will be posted on our website. And she'll also be doing a Facebook Live with a panel on Friday. So be sure to check all of that out. But she helped put together these slides, and I really wanted to share that, when we talk about the impact of stillbirth among African-American and Black women, what we really want to address is why this is happening. And we know that systemic racism, toxic stress, epigenetics, predisposition to certain conditions, access to healthcare, socioeconomic barriers, all tied to why there's such large disparities. So we really want to address this, right? Like, how do we address this together so that we can get to a point where race is no longer a predictor of stillbirth? It's also important to know that research shows education is not a determining factor. A college-educated Black woman is still more likely to lose her baby than a high school-educated white woman. And so here are just a couple of things that we're doing to reduce the disparities that exist. We have that health equity coordinator on staff, like I said. We're looking to expand that role and move it to a director level with a coordinator underneath it. So we're excited about that. We're always looking for funding opportunities to reduce racial disparities that persist and exist in stillbirth. We are an inclusive organization with 100% board and staff trained on anti-oppression and structural racism. We improve our programming based on lived experiences of women of color. We want to elevate women of color. We want to elevate their voices. We listen, and then we work within marginalized communities to ensure that we're reaching everybody that needs to be reached with this information. We have done work outside of typical healthcare settings. We've worked with, through focus groups and community conversations, learning that especially, here in Iowa, people were getting their information from a variety of different sources. It could be their pastor or minister or their grandma and hairstylist. So we did a campaign and a project around faith-based and beauty salons to educate on Catholic Hicks, because you all can talk about this. You all can educate others on this topic. So you don't have to be an OBGYN or anything like that. We should all be talking about the importance of tracking fetal movement. We also have our app in 14 languages. We have culturally appropriate educational material. We have videos, educational materials, and FAQs in multiple languages. One thing that specifically we've done in Florida is we worked with the Healthy Start Miami, had said, when you launch here, we really need materials and everything translated into Haitian Creole. And so we said, absolutely. So we worked with the health department and we got all of our materials also available in Haitian Creole. Our app is available in Haitian Creole. We have billboards designed in English and Spanish and Haitian Creole. So we're really working with you at the community level as well as the state. So if there's ever a missing component that you want to make sure we're addressing or we're sharing, then let me know, because we want to make sure we're meeting your needs and the needs of the people you serve. So just really briefly, I want to give you a little bit background on the research and evidence behind the campaign. So this was created in 2008, like I said, and it was based off this research article right here, which showed when people were educated on the importance of tracking fetal movement in the 3rd trimester. This cohort of women out of Norway, where this research was done, showed that among this cohort, there was about a 30% reduction in the number of stillbirths for those who were educated on the importance of tracking fetal movement. So Dr. Ruth Fretz, she was one of the researchers on that study, and she's also a part of our medical advisory board now. I love this quote that she said, where she says, tracking fetal movement is a non-invasive way for expectant parents to monitor their baby's health in the 3rd trimester. Babies can be saved when expectant parents are educated on getting to know their baby's normal movement patterns starting at 28 weeks and to speak up if they notice a change. This is available on our website. If you really like reading research and evidence, we have a whole page dedicated to it. We recently just launched a white paper that shows the connection between stillbirth and maternal morbidity and mortality, how they're intrinsically connected. So absolutely take a look at our website for additional research and evidence. We've also done our own study on our app users, which we'll talk about here in a minute. But one thing I wanted to share, that I think people have this idea that this is just going to increase anxiety, like you're going to talk about it and then that's all they're going to focus on. Oh, I didn't feel baby move, and things like that. So what I really want to stress today is that this does not increase anxiety. Instead, what you now have is an educated expectant parent who understands what's normal for her baby. And then she has data in her hands with the app where she can go to her provider and say, look, this is my baby's normal and he or she's not moving right. I need to be checked out. So from the study that we did, we found that 84% of our app users stated that regular tracking was associated with feelings of bonding, because we encourage you to, choose the time of day, preferably around the same time, put your feet up and focus on baby, include significant others, include siblings, say, come on, let's go feel baby brother move today. And then we also found that 77% of app users reported feeling less anxious. And the researchers also stated that using a mobile health app to empower mothers to monitor their baby's fetal movement, and that preliminary research shows the mobile health app increased awareness of a change in fetal movement and a reduction in stillbirth. So why are you here listening to me talk today, and how do you implement this? So like she mentioned at the beginning, and I'm probably going to butcher your name now, but I think it's Alima, hopefully you can correct me afterwards. But like she mentioned at the very beginning, this is so important to talk about. This is healthy babies are active babies. And so we want you to start educating expectant parents about counting kicks at the 3rd trimester. So 28 weeks, 26 weeks if they're high risk. Research shows that that's really when baby has really established that pattern that moms can easily track and feel. And so what is a kick? Rolls, kicks, jabs, any sort of movement except hiccups, because those are involuntary. It's like breathing. So those do not count. So now I get to do my favorite part of the presentation. Well, my second favorite. I ask you to multitask. I'm like the only presenter that will say, take out your phones, because I want you to download this while I'm talking. And I know we can all multitask. We're in the United States. We're in a pandemic. We've been multitasking for 2 years or more. So I would love for you to take out your phones and search in your either Google Play Store or App Store on your iPhone. Just search Count the Kicks and click the little clock icon. It's yellow that you see, and download the app, because I want you to use it. I want you to become so familiar with it and see how easy it is to use that you can go to the people that you work with and say, look, I downloaded it. It's so easy. Let's download it on your phone now that you're in your 3rd trimester, and walk through registration and setup together and get you started on this. So a couple features, like I said, it's completely free. There are no ads. There are no pop-up ads or anything like that. It's in 14 languages. If there's a language, I think we're going to be getting it in Portuguese per some feedback from the state that we've received. So if there's another language that you don't see here on the screen that you're like, gosh, I wish they had it in this, let me know, and we will figure out a way to make that happen. Some of the features, so how you use the app is when you go to start counting, you hit that big red button that says start counting. You sit down, you pick a time of day where you know baby's most active, preferably around the same time each day. And you tap that little footprint that you see. Every time you feel baby move, you tap that footprint and a timer will start. You'll do that all the way until you get to 10 movements, and then the timer will stop. And so then what you see is that graph behind that image that will show you a very visual representation of one, how baby moved during that session, how long it took baby to get to 10 movements. And then 2, after a couple sessions, the user will start to see the average amount of time it takes baby to get to 10 movements. So they're going to start seeing the normal amount of time it takes baby to get to 10 movements. That's really, really important, because what we want expectant parents to know and understand is my normal is different than my friend Sarah's normal. It might take my baby 15 or 20 minutes to get to 10 movements, and it might take her baby 5 minutes to get to 10 movements. Same with pregnancies. My pregnancy with my 3rd is different than my 1st and 2nd. So what we really want to do is make sure that they understand this is your baby's normal. So you have an understanding of what your baby's normal movement is. So you can speak up if that changes. So let's say you're counting one day, all of a sudden it took a lot longer. You're going to see that graph visually change. You're going to see it shoot up, which is going to indicate to mom and the user to say, oh, that's not my baby's normal movement pattern. I need to call my provider and see what's going on. And then with the care team together, they'll work through the proper steps and proper protocol to get baby checked out and everything like that. So some other features of it, you can restart a session or delete a kick. Let's say like me, I'm potty training a 3-year-old right now, and I sit down to do my kick counts, and all of a sudden he comes over and says he has to go potty. So if you've ever potty trained, you know, you got to take that kid potty right away. So I have to put my phone down, run to the bathroom, and get him to go. And so I might have to restart that session because I've missed several minutes of my time. So that would skew the results. You can set daily reminders, another great feature. We are busy human beings. We are very busy here. And so being able to set a reminder within the app, you don't have to go out into your calendar. Highly, highly push this with the parents that you work with. You want them to set a reminder, set them daily around the same time. Then they'll get reminders on their phone or watch if they have it to say, hey, it's time to count your little kicker, like just fun, upbeat stuff like that. Really, probably the most important feature here is the download history. Users can actually download their kick count sessions and share them with their provider or share them with their doula or share them with their midwife or significant others. This is really important in times of, especially when telehealth appointments are pretty prominent, especially at the beginning of the pandemic, when prenatal appointments tended to get stretched out, they can still share this information with their provider and say, look, here's how my baby's been moving. I just wanted you to know. They have access to all of that. You can count for single babies or twins. You can track future pregnancies on the same profile, and you can manage multiple devices. So I could count on my iPhone. My husband could have the app and connect and see how baby's been moving. You can include significant others that way. Or I could be counting on my iPad, and tomorrow night I'm going to count on my phone. Or I could be counting because I get notification on my watch. It says it's time to start counting. I'm just going to count on my watch because my phone is downstairs and I'm 8 months pregnant and I don't want to go get it. So just a lot of great features. So absolutely download it so you can become familiar with it. Another feature that I really wanted to mention that just was launched last summer is what we call our strength tracking feature. And this is important because what research now says is not only should we be paying attention to how long it takes baby to get to 10 movements, but the strength of those movements. And so one of the things that we've added with researchers and providers is to say, okay, what's the strength of baby's movement? What was the strength of that session that I just counted? So if you remember, they're hitting the little footprint here. And once they get to 10 movements, the timer will stop. Then they will be shown a screen that you'll see that second image there where it says, almost done. Please fill out the following fields to finalize your kick session. And they have an option to fill out 1 through 5, basically. They'll click on the feet to fill them in color. They can choose anywhere from fluttery, which would be like number 1 and number 2, to fierce, which would be that 4 or 5, which would be movements from the outside. You see like limbs are poking out and things like that. And so they can mark that, and then you'll see they get a bar graph. So once again, it's very visual. The user gets to see 1, how long it took baby to move, and 2, how strong baby's movements felt during that session, as well as the past few sessions. You can also add notes. So let's say they want to say, I was out gardening all day, or I went to the beach all day. Baby felt normal. It was good kick session. It could just be their little diary for you if you want. This last image here is just an example of how visual the graph is. So you can see this user usually took about the same amount of time to get to 10 movements, which is that top linear graph. And then the bar graph usually looked like it was 4 or 5 feet were filled in for strength. So then one day she was counting and it looks like the movement took significantly longer. So you can see that chart go up, and then the bottom one, the strength was down. I'm not saying that that has to connect. I'm not saying that if movement takes longer, strength is weaker. I'm just saying it's important to be aware of both, whether strength becomes weaker and you get the 10 movements, still call your provider. Anytime there's a significant change in movement or strength or both, call your provider. If your provider's not open, go into your OB/ED. You're pregnant, you should go straight to triage. You shouldn't have to sit in the ED department. Another great feature is the video feature that we just added. So people can watch how-to videos within the app. They can watch videos about our equity work, why we count. We don't have all of our videos on there, but feel free to go through these with your clients and patients. It's a great way to become familiar with the app yourself too. So they're just a great feature to have too. And then we also have this new feature where people can enter their zip code in this Find Help resource, and then they can search for things. Maybe they need housing assistance or childcare assistance. We know if we can provide the needs and resources and meet those needs and resources prenatally, we have an option of lowering that child's chances of experiencing adverse childhood experiences substantially. So can we connect people to housing assistance? Can we connect people to doulas and people that, can help them have that healthy, joyous birth experience. This is for free or reduced cost services. So if you use this and you enter your zip code and you know about an agency or organization that should be listed on here for your area, let me know, because this is a continually updated list, and I'd be happy to add them. So this is just an example. I searched my area in Iowa. I found 2,000 programs that I could then search and see what I need help with. So let's just watch this short video together of truly how you can see how easy it is to use the app. So let me know if you can't hear it, because I'm pretty sure I turned the volume on, but we'll see.
The Count the Kicks app, a cutting-edge, powerful tool for expectant parents in the 3rd trimester of pregnancy, has a new feature to help you monitor your baby's movements. The new strength feature allows you to rank the strength of your baby's movements on a scale of 1 to 5, from fluttery to fierce. Research shows paying attention to the strength of your baby's movements is vital. If a baby's movements becomes weaker, studies show this could be a sign of potential problems, and expectant parents should alert their doctor. The free Count the Kicks app now gives you the option to take notes on your session. Our app is available in 12 languages in the Apple and Google Play app stores. It is a simple and non-invasive way to monitor your baby's well-being every day in the 3rd trimester. Features include kick counting history, daily reminders to count, and the ability to count for single babies and twins. Simply tap the footprint every time you feel a kick, roll, or a jab, and the app will time how long it takes your baby to get to 10 movements. Log in to save your kick counting data and get to know what's normal for your baby. Be sure to speak up and tell your doctor if you notice a change in the strength of your baby's movements or how long it takes your baby to get to 10 movements. Hospitals are open 24/7 and are ready to listen to your concerns. Join the community of expectant parents who are in tune with their body and their baby by counting kicks daily in the 3rd trimester. You can also find it on Apple Watch. Download Count the Kicks and start counting today.
So yeah, another great video you can share. It's also on our app. She said 12 languages, it's 14 languages. We shot that video and we updated it. So now that you know about the history, you know about the data, you know what we're doing, you know how to use the app because you all downloaded it while I was talking. How do you implement this? How do you talk about a very sad, tragic subject with the expectant parents that you serve? I know you don't want to scare moms, but I think it's important to understand that we all know pregnancy is full of risks that we talk to people about, and stillbirth is another risk that expectant parents deserve to be educated on, just like we educate on certain blood tests to be taken and certain ultrasounds and why we take folic acid and don't drink. We should educate on stillbirth and stillbirth prevention as well. Or you think stillbirth just happens, there's nothing we can do. There can be warning signs. And if expectant parents know what to look for, reduced fetal movement is one of the first and sometimes only warning signs that baby's in distress. So it's really important to understand what's normal for your baby. Here's a big one that you're going to get when you talk about this with your clients or patients. They're going to come back and say, I don't need to do that, baby. It's like a jungle gym in there. I don't need to count baby's movements. I'm not worried. And I always respond with, that's awesome. A healthy baby is an active baby. It's just so important to continue to count your movements so you know if your normally active baby has changed. And what the app does is it helps take the guesswork out of knowing exactly that, knowing if your normally active baby takes 5 minutes or less, or is it 10 minutes or less? You don't have to second guess yourself. It's all right there in your hands. So continue to count the kicks and monitor fetal movement. She's almost at her due date. If you work with a lot of multi-generational families, this might be something you experience too. The risk of stillbirth actually increases as mom approaches or exceeds her due date, and it increases quite a bit too. So that's a myth. You might find yourself having to talk about count the kicks and fetal movement monitoring with those who have tragically had a stillbirth. So you might be thinking, what do I do? And you do exactly what you would do with everybody else. Everybody deserves to know about this. And the people that we've talked to who have had losses had said, I've had previous live births and nobody said anything to me about this. Nobody told me I should be doing this. And why didn't I know? So we want to turn that why I didn't know to, I'm so glad I knew. I'm so glad I knew to speak up. I'm so glad I had this data in my hands so I could speak up. So you want to follow the same protocol with somebody that's had a stillbirth previously. You know, if you don't know about it or they bring it up, you want to start tracking fetal movement at 26 weeks because they're already at a higher risk of experiencing another one. Feel free to ask them questions about their previous stillbirth if they're willing to talk about it. Be empathetic, ask the name, the gender, asking if anybody's talked about this before. So you would just educate them just like you would anybody else. Here's that active one again. So here's some common myths. Again, even active babies can experience distress and sometimes quickly because you're normally active baby and you're busy all day. And then you're like, sit down and you're like, have I felt baby move today? You just don't focus on it. So you could have that time of day where you normally count and that you could figure out what your baby's normal movement is. Here's a common myth. Only those experiencing a high-risk pregnancy should pay attention to their baby's movements. We want everybody to do this. We don't just ask about gestational diabetes and have us all drink that wonderful liquid for just those at high risk. We have everybody do that. You should be talking about count the kicks, fetal movement monitoring with every single pregnant person you serve. No questions. 10 and 2, I'm glad you brought that up at the beginning. That's actually outdated information. That's a common misconception, actually. You hear it all the time, 10 and 2, it's easy to remember, it's easy to understand. But what current research has shared, and it's on our website too, if you want to read the evidence, is that expectant parents should get to know what's normal for their baby. And so they should get to know what's normal for their baby to get 10 movements. So what this research study showed basically was, as human beings, we focus so much on the time. We focus so much on that, so much in fact, that let's say I'm counting and I normally take 15 minutes to get to 10 movements, my baby does. And one day I'm counting and it took an hour and 47 minutes to get to 10 movements. But I think to myself, that's okay because my doctor said 10 and 2, so I got it within 2 hours. But what we really need to understand is my baby normally takes 15, 20 minutes, not an hour and 47 minutes. So we want to move away from that mentality and focus more on what's normal for your baby and your pregnancy, and to speak up if that normal changes. Here's another big one. I know there's apps out there that you can do a Doppler device. Some people don't realize a change of baby's heartbeat is one of the last things to occur when a baby's in distress, whereas the change of movement is one of the first things or only things. So if you think about it, when you and I are sick, we just want to sit down. We don't want to do much. We just want to lay around. We want to, rest and sleep. Same with baby in utero. They're not going to move as much. They're conserving that energy, whether it's due to an infection, umbilical cord, low amniotic fluid. They're not moving as much because of something. So we need to be aware of that so we can speak up if we notice a change. Here's another common one. We should drink juice. We should jump up and down. I've heard, you might call your provider and they say, oh, you should do X, Y, and Z and call me back in 2 hours. Research has also moved away from this, that we want fetal movement monitoring is best done without interventions. And it goes back to when you and I are sick. We don't want to, when we're sick, we're not chugging Mountain Dew and candy bars to get our energy up. We're sitting there resting, trying to get better. So same thing with baby in utero. We don't want to have interventions to force baby to try and move. If baby's not moving like normal, trust your instinct, trust the data if you're using the app, and go into your provider. Babies kick less than a year end of pregnancy. They just move differently. I think that's an important one. That's what like my grandma would say, baby's running out of room. It's just baby's getting bigger. So the movements might feel a little bit different, but they should still get the same amount of movements in the same amount of time. They should still get those 10 movements around the same time. If you work with labor and delivery triage, or people that work in labor and delivery or OBs, they should have this information. I went to triage 3 times with my daughter for various reasons. Everything checked out totally fine, got sent home. How amazing would it have been to have a triage after visit summary doctor note that said, here's how you count fetal movement, and have the brochure handed to me. So I think some people think, oh, they're there, they're going to get admitted. No, like I'm sure there's percentages out there of how many people come in and get sent home. I mean, I did it 3 times. So they should also have this, just like you should have it in your office. You should have it with your locations. Dental care is another common one. You should always be practicing good oral health care, encouraging your expectant parents to visit the dentist and go there as well. So other ways to integrate, can you add this to any sort of team notes or family care plans or intake documentation? Can you have your front desk staff trained, you know, when they're setting up an appointment for their next meeting, can they say, hey, have you heard about Count the Kicks? I see here you're 32 weeks pregnant. Here's a brochure, download the app. There's lots of different ways you can integrate this. I'm not sure who's all on the call today, but I'd be happy to talk to you whether you're in a clinical setting or more of a CBO setting, public health setting. I love systems change. I love finding ways to integrate this into your workflow so you don't have to remember, you don't have to think about asking about this. It's just easy. It's right there in your face so you can share this. So absolutely reach out to me. I'm happy to talk about this. And some other ways, electronic health medical records. We want you to be talking about this every single time you see them. So if you are a home visitor listening today or a WIC and you see them a couple times a month, you're going to talk about it every single time you see them in their third trimester. If you are OBGYN listening or midwife or doula, you're talking about it every single time you see them as well. So it doesn't matter what area of focus you're in. Every time you see that mama, you're going to be talking about this. This is baby Margot. She was saved in Ohio where, you know, her mom said, I'm very fortunate that my OB office shared the Count the Kicks information with me through posters on the room walls and a brochure. It's encouraged me to download and regularly use the app, which is how I knew that my baby's normal movement pattern had changed. So we love those stories. We shout them from the rooftops. And so if you know, if you're using this and somebody comes to you and said, thank you so much for telling me about this. I saved my baby. I noticed reduced fetal movement. I spoke up to my provider. Baby's here because of it. Let us know, because that's what we remember. That's what your expected parents will remember, is that those stories. And we'll share a baby saved story at the end here, but it's just amazing and remarkable and why we do what we do. Here's another example out of Ohio. This organization, Celebrate One, focuses, they serve about 2,000 primarily Black women every year. And they wanted to integrate Count the Kicks in a way where they don't see them every time. They usually they do these different events and stuff, so they don't see them routinely. So how could they make sure to integrate this if they only have that touch point once? And so we worked with them on adding this language to their intake form when everybody goes through. So again, happy to connect with you and figure out ways that we can do this in your agency. So now here's my other favorite part of multitasking. I think I have a couple minutes to do this, but as I'm talking, usually I play this Happy Song by Pharrell Williams, but I'm not sure I have time today. So I want to share that while I'm talking about this, scan the QR code that you see on your screen or type in the website, go to order materials and click on Florida, because all the materials are free. And I love doing these presentations because then I get emails and I say, so-and-so place an order, so-and-so place an order. And so I think, take advantage of those free materials. They're in English, Spanish, and Haitian Creole. What you see on your screen here, sorry, I didn't put Haitian Creole on here, but what you see on your screen here is our how-to poster. So we have a how-to poster, we have a promo poster, we have brochures, and we have app reminder cards. And we also have low literacy materials for Florida. So materials that are a lot more picture heavy. And maybe if you work with refugees or people where English is not their first language, those pieces would be good for those. But any of the materials completely free, thanks to our partnership with Florida Department of Health. So go fill your shopping cart and make an order. These would be good to have in your car if you move around a lot and you're meeting people where they're at. Keep a stash in your car. You can drop them off at libraries. We have libraries that order these. You can drop them off. Like I said, you are boots in the ground. So can you take them to an OB clinic? Can you take them to an emergency room or a family care doctor? Could you put them in your waiting room? Can you put them in your women's restrooms? Can you put them in your patient workrooms, if that's what you have? So there's just so many ways that you can utilize these. And then we have magnets. That's new this year. So take advantage of that too. You can get a bundle of magnets that you can hand to moms. So you can hand the brochure and the magnet and say, go ahead and download the app. And we're going to talk about this the next time I see you. Like, start counting. You're in the third trimester. You need to understand what's normal for your baby. So like I said, normally I play this music for about 2 minutes, but I thought I'd just talk to you today about it. But yeah, go ahead and scan it and I'll send this out too. So you all have it and I'll put it in the chat. But absolutely take advantage of that. We also have an online CE training where you can get credit. I'll send this link out to. Use the code SAVEBABIES-FL for Florida, and you can take it completely free. We just are working on adding a whole equity and inclusion section to it, and that should go live within the next couple of weeks. So use the code, take it for free, get 1.5 CMEs. We also have state-specific websites specifically for you in Florida. You can access these websites. You don't need to jot this down. We'll send out the links, but there's one that the Florida Department of Health has put together. And then we have one of our own where we monitor like how many materials have been ordered and how, you know, just various webinars and trainings will be on there for you to see specific to Florida. We also have a lot of great digital resources that you can share. You can share the Parent Academy with the parents that you serve. Provider Academy has childbirth education sample lesson plans. It has print charts, print Kid County charts. If you work with somebody that maybe they don't have a smartphone, or they don't always have Wi-Fi availability, you can do that. There's videos, and these are just some of the baby faces, some of the baby saves when people contact us and say, I was using your app, or I knew about Count the Kicks because my home visitor told me about it and my baby's here because of it. We have close to 100 on our website. I would absolutely share these stories with your expectant parents because, like I said, this is what they're going to remember. This is what you're going to remember today. You're going to remember baby Nala's story and how she was saved by her mom. And it's just going to put a smile on your face and it's going to make you feel good. And this is what you're going to want to share with everybody you work with. So let's go ahead and watch and we'll wrap up.
She came back in after she had me put on the monitor and stuff. And she's like, we're just going to take her. And I'm like, what? And she's like, you know, her heart rate is dropping every time you have a contraction. I was already scared, you know, because I was a high-risk pregnancy. So I basically learned from the doctor's office, the little yellow sign that was right there. When she started moving, I was very alert with her movements, you know. That was what I lived for, just because I wanted her to, you know, her to make it and survive. When she started moving, she moved, and she was consistent. It was always at a certain time. Nala was a kicker. When she started kicking, she was kicking. And this day, she wasn't moving at all. I started drinking cold water. I mean, I was drinking so much, my stomach was hurting to make her move. And she didn't move at all for me at all that time. So I'm just like, okay, I'm gonna get her checked out. It was the heart rate that was dropping. Like they said, her heart rate would drop real low every time I would have a contraction, and they were like back to back. She thought that it would save the baby, so she pulled her out. She was like, it's a good thing you came when you did, you know what I'm saying? Because if you wouldn't have, you know, we probably wouldn't be having the same outcome. I think about it every day, like, oh man, what if, you know, what if? Definitely to pay attention to count the kicks, you know. I feel like it's important just because had I not, you know, knew to do that, Nala wouldn't be here. Don't second guess yourself. Don't feel bad or stupid. Don't worry about insurance or the emergency room bill. Go check on your baby, you know, because your baby might not be here. You just pay attention, you know, seriously. Like, it's your baby's life.
So I like what Dana says at the end where she says, don't feel bad or stupid, go check on your baby. I think that's an important message too, like trust that instinct. Don't let people second guess, you know, make you second guess it. So just wrapping up, this takes 3 to 5 minutes. This does not take long to educate on and share with the patients and clients you serve. So make sure you order the materials, become familiar with the app, make sure everybody knows on your team about this. Reach out to me if you want to figure out ways to integrate this easily into your workflow. Remember, hours and minutes matter in preventing stillbirth. So if you have somebody that lives 40, 50 miles away from a birthing center, make sure they have that game plan of not waiting for a message to be, you know, sent back or something like that. If they have concerns, they need to get going. And then, like I said, we have a lot going on this week for Black Maternal Health Week. So feel free to reach out to us, sign up for our newsletter to be in the know. We have a Facebook Live event happening Friday at 10 a.m. Central. And then we have that great discussion that was supposed to be 90 minutes and it ended up being like 2.5 hours yesterday with wonderful, wonderful individuals. And so be sure to check that out on our website too, and you can rewatch it. So yeah, I'll stop there and happy to answer any questions. Thank you so much for your time today. I'm sure I butchered your name. Is it Lima? Be happy to know. I'm so sorry if I did. Oh, sorry, you're on mute. I missed it.
Okay, no, I said it's Alima. I said, come on, baby.
Alima.
I'm trying to get yours right now. Come on.
I know. I almost said Alima too. I was like, I bet it's Alima or Lima. I feel like it's Alima. I should have gone with my instincts. You guys trust your instincts.
Go with your gut, right? Come on.
I did. I'm not even listening. Yes. So yeah, thanks so much, Alima.
Well, thank you so much for being here. That was such great information. I just want to let you know. So we do work with all the OBs in Broward County, and every OB has it. We try to get it out to them. We tell everyone about the app. I have the wristbands that you send because I do a lot of frequent orders and the magnets. And we recently just had someone who didn't work for Healthy Start, but she worked inside of the office building and she was pregnant. And every day I used to ask her, and I gave her the wristband, and she would, she said she didn't really have time to do the app as much because she was always actively working, but she would use the wristband because it moves. And she would use that to count the kicks. So it's just, awesome. And, one of the main reasons why we were doing this and we thought about these topics for this particular Black Maternal Health Week workshop is because we just want to, I push the message that it's everyone's responsibility. This is a shared responsibility. It's not just on mom or it's not just on doctor. I want everyone to speak the same language and make it universal. So that way, when the mom hears it, she knows, like I should be counting my kicks. And just like I said, this young lady who we didn't work together, but I used to see her in the building and it was like, I know she's pregnant now. It's my responsibility to remind her every time I see her to make sure she's counting her kicks. So much to that point where she even like messaged me, once she had the baby, we ended up exchanging numbers and it was like, it felt great that I'm like, hey, I made sure. She said, every time I see you, I think about it. And I love it. Every time I see her, she had the wristband on. So again, like I thought your presentation was amazing. You covered every talking point. I was like, writing down things like I'm going to ask her to speak on this, once it's time, but you really hit it on the nose. So I'm going to see if we have any questions. Thank you. Right now in the chat. I hope you all downloaded the app as she told you to, and also to order the materials. They're free. Yeah. If you live in Florida, they are free. No shipping costs. Like she said, there are different languages. They have like low literacy, meaning just like very picturesque. When you look at very straight to the point. So there's different kinds. There's the posters, there's the fold brochures, there's the little cards that they have. They send out the free magnets. So sometimes, like I said, I got these wristband goodies in one day and we're giving them out to mom. So the information is free. Order it. Oh, go Christy. Right there, delivered straight to you. So we want to make sure that you guys are using that to pass along to these moms and families that we're helping. So again, she put the information in the chat, counttthekicks.org to be able to order. Christine says she just ordered, great resource. So just thank you so much. So again, I'll give another second or so to see if anyone has any questions. Or Megan, how would they reach you? Like say for future references, that if they wanted to set something up like this, to have you come speak to a certain crowd of folks, how would they go about reaching you or getting someone from Count the Kicks a healthy birthday?
Sure. That's a great question. I just sent my email in the chat, so you can email me directly and I'll get you connected with either a health equity coordinator or, me or Jen. Just, we have a small but mighty team. Is Broward close to Miami? Are you guys? Yes. Okay. So when we, Miami, they'll be like, how many orders have come in from Miami? And you guys are always like, seem to be in competition with each other. It's so funny to see. It's like Miami and then Broward's right there of how many orders have come in by month. So props to you all in Broward, because that's amazing. And I'm sure it's nice and sunny there and not 34 degrees.
Well, I will say I'm born and raised in Philadelphia, so I know all about the cold weather.
Okay, you got it. Yep, you know.
Yes, I know about it. I do miss the snow at times.
Right.
And it was just funny. I was teasing my friend. I still have a habit of checking the weather there. I don't know why, but I still have a habit of looking. And today was like going to be a warm day. I said, "Oh, look, you're finally getting some heat." So hopefully, Iowa will warm up soon.
Yes.
So you can get some of the heat as well. Okay, let's see. Yes. Broward is just north of Fort Lauderdale and just below Miami, and the number of versus here 20,000 last year. So
okay, I should have.
They're pretty cool.
Yeah, I should have looked at your compared to Broward and Miami, like the comparisons for stillbirth rates and things like that to see if you're that close. So, but you can access that on the Florida website too. But yes, thank you so much for this opportunity, Alima. I'll send you the links directly so people didn't have to scribble those down for like the CE training and videos and things like that. But you all do amazing work. We could not do this without you by any stretch of the imagination. So hats off to you all because you're doing amazing work and we appreciate it. So thank you.
Well, thank you so much. And Esther Singleton, she wanted to point out, as a prenatal educator, lactation consultant, this information is great for classes and one-on-one
Yes.
lessons. So again, like I said, everyone's responsibility. It's not just on one person.
Mhm. I love
Moms are
that.
going to get, childbirth education, breastfeeding education. They're reaching out to different people to try to prepare them on this journey. And I'm just hoping that everyone that's on this webinar today that's receiving this information did scan the QR code and Megan put it up, or go visit countthe.kicks.org to get this great information, to give it out, because like, again, I want it to be universal. And I'm sure it touched on the video, but it goes on your Apple Watch, your Fitbit watch, your phones, Android. So there's so many ways for the mom to receive this information. And if you need a wristband, I'll get you the wristband or the magnets.
Yeah.
We just want to keep trying to figure out ways for moms, to get it and to use it.
Yeah, the wristbands, you won't find those on the website. Those were specific to Healthy Start. So yes, reach out to you, Alina, if you have some. So yes, I think next year they'll plan on putting those out on the website. That they were pretty successful. So it was just kind of like a pilot. So I'm glad you liked them and that you found them useful. And yes, we would be happy to present to expectant parents. So just reach out to me, Christine, and we can get something set up, and see what you need. Have to be virtual, obviously, but as much as I'd love to go there. I was supposed to be there last year for a conference and it got canceled because of COVID, but I'm actually going to Disney for the first time with my children and husband in like 40 days. So never been. I hear it's going to be hot when I'm there, but I'm used to humidity. So hopefully it's not.
It's warming up, but it's one of our favorite places to go. There's a few team members that's on the call, and I know we talk about it often. So we're gonna have an amazing time. Good. For sure. But again, so let me just check and make sure I don't have any more questions. I know you just answered Christine's about being able to present, and she put her email in the chat, Christine, so you can reach out to her. But again, thank you so much, Megan, for coming. And I really, really appreciate you and everyone at Count the Kicks and Healthy Birthday for, presenting this opportunity and just giving this resource to the people who work close with the families in Broward County. So thank you so much. Enjoy. Bye. I hope you get warm soon and enjoy your time at Disney when you come.
Thanks, everybody. Have a great day. Bye.
All right, folks. Well, that was great. And again, I hope you all are enjoying this great information. I hope you're taking notes, getting these resources and just the people who are help making this happen. So I think everything is moving along and great so far. So we're going to take a quick break. Let's say everybody be back at about 11:56. To give you 5 minutes, stretch, use restrooms, whatever you need to do, get some water. And we'll have our last presentation when you return from Dr. Sasha Davidson. She is a perinatal in Fort Lauderdale. She's been in obstetrics and gynecology for years and has, great credentials and accolades. And she's going to talk all about lowering C-section rates and how we can play a significant part in that. So stay tuned, take a break, and we'll be back soon. All right, we are back. I hope everyone has stretched, got a drink of water, was able to take that quick break. We're gonna get on to our next presentation or with our next presenter. And then we'll wrap up for today. So next up, we have Dr. Sasha Davidson. And it seems like Dr. Davidson was originally a South Florida girl, and she received her undergrad degree at Miami University, I believe, and then moved on to do her master's and get her medicine degree up north at Georgetown University and did a residency at Johns Hopkins. So like I said, this doctor has a lot going on, and she's down in Fort Lauderdale with her practice, which is Signature Perinatal, and where she treats high-risk pregnancies. So we're going to bring on Dr. Sasha Davidson. So grateful for her time today. And again, she's going to present on lowering C-section rates. So let me just go on and find her. And again, after that, we are going to wrap up for today. I hope you found all this information very helpful. And let's see here. I want to locate her on here so we can bring her on and we'll get started. Okay. All right, just give it a second and we'll bring her right on. Let's see. Here we go. All right, well, good morning / afternoon, Dr. Davidson. I see she's going to be coming on and she'll take it away shortly.
Hi, good morning.
Hi, good morning. I'm like, it's like 1 minute to the afternoon, so good morning / afternoon.
Good morning / afternoon. I hope you all have had a pleasant morning so far, and I'm glad I could join you.
We are so happy to have you. So without further ado, if you want to go ahead and share and take it away.
Absolutely. Let's do this here. Doing multiple screens, as you can imagine.
I know all about it. I said, it's not fun if it's not live, right? So it's all good. We have some people in the chat that are very excited to have you here today. So they say, welcome, hello. We're so grateful and appreciative of you doing this for us. And just being able to educate those who help the ones in our community. So I'll give you some time to get it up and then you can take it away.
Okay. Here we go. Start here from the beginning. All right, can you see my slide?
Yes, you're good to go.
All right. Well, thank you again for inviting me to be a part of this webinar and to use my voice, not only as a woman of color, but also as a double board certified obstetrician. I'm not only certified as an obstetrician gynecologist, but also as a maternal fetal medicine specialist. And I have the privilege of caring for variety of women from multiple backgrounds. And I've had a varied experience. I did deliver babies at one point in my career as a practicing OBGYN in the Washington, D.C. Metropolitan area, Baltimore, where I trained in my residency at Johns Hopkins. And so I feel that I have a vast experience set that hopefully I can offer you all a little bit more information on this topic, although as you will see through my talk, there's so much to go through on such a broad topic that has been never ending. So again, thank you for the opportunity to speak with all of you today. So I was given the task of talking about cesarean delivery birth rates. And the question is always, how can we reduce the C-section rate? And so where are we now in 2022? So I'd like to start off kind of going through that. And if anybody Googles, they'll see that even just in the last 20 years or so, even going back to 2015, this topic is just always a big issue. So the highlights of 2015 are sky high C-section rates in the US. They don't translate to better birth outcomes because that's what we all know, right? C-section was developed to improve birth outcomes in babies who needed to be delivered, not vaginally, but by the abdominal route for a variety of reasons. And usually those are medically indicated reasons. And back then, the highlight was women in the United States are giving birth by cesarean section far more often than is necessary to keep maternal and neonatal mortality rates low. We jump now to 2018. And again, rate of C-sections is rising at an alarming rate, says this report. In 2019, the rise of C-sections and what it means. So year after year, this topic continues to challenge us in not only the obstetric community, but in the medical community, because we're not the only ones looking at this subject matter. Even more recently, in December of 2020, in the midst of an pandemic, unnecessary C-sections are a problem in the US. Will publicizing hospital rates change that? When I practiced, there were hospitals that I worked with that used to publish my C-section rate and that of my partners. It's used as a tool to kind of monitor us physicians to improve our ability to offer and provide patients with vaginal births. So we were always in a conference room sitting around each other and it's like, what's your C-section rate? What's your C-section rate? Because it really does matter to us. Again, in March of 2021, now it's becoming even more global rising rates of cesarean sections. So it's not just a question or an issue that's plaguing us here in the United States. It's a global issue that many clinicians around the world are trying to understand a little bit better. And lastly, June of 2021, cesarean section rates continue to rise. And now the caveat is amid growing inequalities in access. And so now the topic is bridging the gap of women who do not have access to care and also women of different backgrounds and cultural backgrounds and sociodemographics, African-American populations. So the conversation has now started to include that because they're looking at the numbers. So where are we now? The National Center for Health Statistics in their 2020 birth data, out of the millions of pregnancies, there were about 2.4 million pregnancies in the United States. And there was 1.5 million deliveries, but that were occurring by C-section in 2020. And that represents a 31.8% C-section rate. So nationally, we have known that the C-section rate is about 30%. We globally say 30%. Well, how about where we are here in Florida and nationally? Let's look at this. I do want to focus though on our state. So the colors here represent a C-section rate, with the green being the state, with the darkest green being the state with the highest number of C-sections. Here is that representing 35 to 38%. And as you can see, Florida is in that group. When is Florida never on the map, right? Even when it comes to C-section deliveries. And to be honest, there's certain, they break up the counties up, and they even actually break it down even more and look by counties. And I think Miami-Dade County continues to be one of the highest C-section rates, and for a variety of reasons for which I actually don't have the answer, but certainly many of us suspect that there are a lot of cultural differences that may impact that as well. So we've made the top 10 list in Florida. So we're number 3 in the US, Mississippi being the first, Louisiana being the second, and here we are 35.9% here in Florida. And as you look through the rest of this list, you'll see Texas and West Virginia, Connecticut, Arkansas, and there's something about that, looking at what states are represented, the southern states. And let's think about the population of patients in those southern states. Again, women that look like you and I. It's interesting, I saw Connecticut on that list being 34.1%. And it's a little different, right? Connecticut is in the Northeast. And so again, there are different variables that might lend itself to understanding why certain states have a higher C-section rate versus others. But I think cumulatively looking at this list, we can see that a lot of the southern states are affected. So what is a C-section? We all know what it is. The point is not to, behoove this conversation of, C-section is delivery abdominally, but it's important to highlight that this is actually one of the most common surgical procedures performed worldwide. Advancements in anesthesia and also in antibiotic therapies in the early 19th century actually helped to improve maternal deaths that were due to childbirth. So, the initial thought of a C-section was that it actually helps to improve outcomes. And over time, with the advancements in the late 1800s, that's when we saw that this became more of a phenomenon for allowing women to give birth safely. Now, back in the 500 BC, I'm giving you some phone a friend tidbits. It was in the Roman law, Lex Reglia, and I hope I said that right. But there was this law, and it was religiously based, that a woman could not be buried with a fetus in utero. And so they did perform these procedures, these abdominal C-sections, so to speak, as a way to follow this religious law. Now, Jacob Neuffer, he was actually I think he was a pig. He did something with pigs back in the 1500s. Like he did surgical procedures on pigs, but he performed the first C-section on his wife in the 1500s, and actually is credited as the first person to perform a C-section. And the story is that his wife went on to have 5 more children, all vaginally. So you can also give him credit for VBACs as well. But I thought that was an interesting tidbit that I wanted to share. So let's talk about some of the factors that are associated with an increase in cesarean deliveries. And there are a multitude of factors and a lot of medical, but I know the purpose of this talk today is not to stick to just medical. We want to look at other factors that could be impacting the increase in cesarean deliveries. And I know we hear a lot about this in the news as well, and social media, but I wanted to highlight some of these factors, particularly the advent of maternal obesity. It really is a challenge for us, not only in obstetrics, but in all of healthcare, because we realize the implications and the long-term effects of obesity on not just your well-being, but that of a developing fetus and the future of that newborn. So what is it about obesity that can increase the C-section rate? Well, we know in healthcare and in pregnancy that there is a change in medication dosing, and that increases as pregnancy advances. There's this, that your kidneys are filtering out medications at an increased rate during pregnancy. So certain medications, I, as a high-risk perinatologist, often have to discuss increasing dosage of medications to meet the level and the requirements that the mom will need. So same thing goes for labor and delivery. If we are inducing and we are increasing medications such as oxytocin, certainly obese patients might require a higher dose. And that limits us, especially if hospital protocol contradicts our need to increase the oxytocin rate or dosing, right? And so we are then stuck saying, boy, we can't increase her medication dose, even though she might need to be increased. It goes against hospital protocol, and hospital protocols are set to increase safety. And we do not ever want to cross those barriers, because at the end of the day, we always want to make sure that we are thinking about the safety of the patient first. So I think that's one limitation and one factor in this discussion, is that, you know, the need to increase medication, and inadequate pain control is also an issue. I know many of my patients will tell me, and I'll ask them, so why did you have that C-section, you know, for your first delivery? Oh, you know, my labor was just so long. I was so frustrated. I just decided to ask my doctor for a C-section. And that's where we, again, another factor increasing the C-section rate is that there is a maternal request, because there's this frustration of the labor, the length of labor being so long. And I think that goes back to actually one of the points I have here, is that I think educating our patients about what labor is about, what labor is like, and the length of time that it can take, you know, not to give up. Yes, it might be a long time, but there's a value in being patient through this process. Again, maternal discomfort due to inadequate pain relief and anesthesia. You know, there are several hospitals here in our local area that may not have dedicated anesthesia service. And because there's not an anesthesiologist readily available on the unit, I think that really does impact our patients. There are oftentimes, I know, where I have to do a procedure of some sort, and I have to wait for the anesthesiologist because they're being called to a trauma in the trauma bay, and, you know, no one is available readily. So I think that is an important piece of the puzzle too. Having in hospital services provide the adequate anesthesia so that patients have the ability to request pain relief and be more comfortable during the labor process. Advanced maternal age, we know that that is also a risk factor for increased cesarean deliveries. You know, women, we're now delaying our childbirth until later in age. And many have that thought of mind that, look, I've come this far, I've waited this long, a C-section is safe, let's just get this baby delivered safely. And so they're requesting maternal request to have a C-section. That's just one of the facets under the category of advanced maternal age. There are other reasons why women of advanced age also have cesarean deliveries. And now here in South Florida, we also have to be conscious of the language barriers and cultural differences that exist. There are a lot of patients I care for from the Caribbean, from South America. And again, they come with a different thought process as to how labor should progress. And a lot of their friends have C-sections, and sometimes patients don't understand. So I think that also has a real impact on how we are able to communicate with our patients and wanting to provide them with the best. And then, of course, we can't finish this without talking about the celebrity effect and trends that go on in our social world and our social environment that lends itself to patients wanting cesarean deliveries. Let's talk a little bit about induction of labor, because that comes up quite a bit amongst my patients as well. You know, I think that there's this thought that pregnancies are, you know, to be normal and healthy, babies need to be in until 41, 42 weeks. You know, there have been trials and research studies that have been done to kind of look into this question of induction of labor and whether inducing labor a couple weeks earlier is of value and of benefit for the patient and the newborn. And there was this large randomized trial called the ARRIVE trial. And I don't want to, you know, take this to nerd zone, but I do want to highlight this very important milestone in the obstetric world. So this randomized controlled trial, so randomized meaning that the patients, they don't know what group they're going to fall into. And so they either fell into the group that were being electively induced at 39 weeks, or the group that said, we'll just wait until nature takes its course. So those two groups, and they looked specifically in low risk mothers who were first time mothers. And so they were looking at 41 facilities across the US, and they blended it up, they mixed it up. It wasn't just an academic institution like the University of Miami or Johns Hopkins or, you know, Georgetown, but they went into the community hospitals. They involved places like a Northwest Medical Center and a Boca Regional. So although those weren't the hospitals in this study, I'm just using that as an example to show you that there was a variety in the choices of patients, because different types of patients go to different facilities. So the major outcome that was being looked at in looking at these two arms was actually the C-section rate, right? Now, does inducing labor at 39 weeks increase the C-section rate, or does waiting till nature take its course impact the C-section rate? And what they found is there was a significantly lower in the labor group. 18.6% of them ended up with a C-section versus 22.2% in the expectant management, the ones who waited until labor took its course in those two groups. And there were no significant differences based on race or ethnic group, maternal age, or body mass index as a sign for obesity. So they really took a step back and they said, let's look at the race of these patients. Let's look at the age. Let's look at the obesity. Did any of these confound or have an impact on the C-section rate in these two groups? And both groups had similar numbers of African Americans, women with a BMI above 30, et cetera, et cetera. And what they found is that really there was no significant difference in the C-section rate amongst the two groups. So based on these results, there have been policies previously aimed at avoiding an elective induction among those low-risk patients. It's really unlikely that we will reduce the C-section rate if we say, okay, no deliveries at 39 weeks, let's wait until 40, 41 weeks. There really is no significant difference. So how do we use this information to now approach the patient? I took this deliberately from the society and from actually the trial itself. It says, based on the findings of the trial, it is reasonable for obstetricians and healthcare facilities to offer elective induction of labor to low-risk nulliparous women at 39 weeks. However, consideration for enactment of this elective induction of labor intervention should not only take into account the findings of the trial, but that this recommendation may be conditional upon the values and the preferences of the pregnant patient, the resources that are available to the doctor, and the setting in which the intervention is being implemented. So a collaborative discussion with shared decision-making should take place with the pregnant woman. Additionally, as induction of labor involves coordination between the healthcare provider and the infrastructure in which induction and delivery will occur, it's critical that personnel and facilities coordinate policies related to offering an elective induction of labor. So what I take from this is that patients have a choice. And I think it's important as patients to discuss this with your doctor and your provider. Yes, there might be medical rationale and reasons for inducing your labor at 39 weeks. As a maternal fetal specialist, there are many times I recommend delivery at 39 weeks because my goal is to improve the outcome of the pregnancy and the fetus and the newborn. And so I make those recommendations based on clinical information and data. So I'm using the whole picture to counsel my patient and say, look, I'm recommending delivery at 39 weeks because you have a fetus that's abnormally growing. This cannot improve in the next 2 weeks. There are concerns for stillbirth, XYZ, and I go through and I counsel and I individualize the care of the patient. And I allow them to be a part of the discussion and ask questions. So I think from that trial, that is really the best approach to patient care. And the national societies back that up, right? Current guidance from the American College of Obstetricians and Gynecologists and the Society of Maternal Fetal Medicine, they recommend that if the maternal and fetal status allow, if everything is fine, cesarean births for failed induction of labor in the latent phase, latent meaning the patient's not in active labor yet. They're still just having, some irregular contraction pattern. They're still maybe 3 centimeters dilated. Don't give up. The cesareans can be avoided by allowing longer durations of the latent phase, up to even 24 hours or longer is what they're saying. And sometimes we might require oxytocin to be administered, especially in the setting of a woman who's broken her water. It's allowed as long as there's no evidence of an infection, for example, and that the baby is tolerating the labor process well, it's okay. But I don't think patients know this part. And I think it's important to educate them during the pregnancy and during those last few weeks of pregnancy where they're coming in weekly and saying, this is what you can expect during the labor process. It might be a long course. but it's okay that it lasts up to 24 hours. And I think that's the piece, as I mentioned before, about factors that patients sometimes give up because it's taking too long. And I know we're in the day and time of hurry up and right now, but I think labor and pregnancy and birth is really such an important part of our life that it's okay to take the time. I wanted to highlight vaginal birth after C-sections, aka VBAC, and also trial of labor after cesarean. That's a lot of the terminology has changed back and forth over the last few years. So sometimes the literature will call it trial of labor after cesarean, TOLAC. So some of the barriers to VBAC are hospital policies, right? Because I'm hoping that patients are aware and informed when they do desire VBAC. It's not that you can't deliver your baby after a first C-section, but there's risks involved. And one of the risks is the fact that there's a small chance that the scar that was previously made on the uterus could rupture, could tear because of the weakness in the muscle. And so for that reason, it's really important that if you're doing a VBAC, it should be done in a hospital setting. Now, I've heard various scenarios in which VBACs are being done. I'm speaking from a physician's perspective who ultimately took an oath to do no harm. And so when I do VBACs or did VBACs, it was always in a hospital setting. And so I will always encourage patients to be in a hospital setting. But I also acknowledge that there are other settings that other providers may offer their patients. So hospital policies, because of the concern and the risks involved, many hospitals do not want to take on the risk. And it leads to my second point here about malpractice, right? Malpractice insurance providers will say to a hospital, we're not going to give you this malpractice coverage because you're going to be doing and offering these risky procedures. And although we in the community know that, yeah, it's a safe procedure, but again, when it comes to financial backing and financial, incentives, there's definitely a struggle in getting those with the ears to listen and make that change. The other piece of this, I talked about the availability of anesthesiologists 24 hours. There's some hospitals, again, who do not have the availability of 24-hour anesthesia. And I think anesthesia is an important part of this because in the event for the need for an urgent intervention during a VBAC, the anesthesiologist needs to be readily available with the obstetrician to help care for and to expedite the delivery if an emergency arose. And I must also add that provider personal experience does impact the decision to offer the patient a VBAC. I myself have, when I worked at Washington Hospital Center in DC, I remember a Sunday morning, I worked with residents and other colleagues who were part of a big group. There was always a doctor in house. And it was a Sunday morning, I was getting sign out from the residents and the doctor who was on call overnight. And the nurse called us and she says, well, room 2, the baby's heart rate tracing is dropping. And we ran like you wouldn't believe to move that patient from her labor room to the operating room. And by the time I made my incision and got in, the baby was floating in the abdomen because she had a uterine rupture. Those stories don't happen every day, but they do happen. It's not that rare, but it does happen. And it has happened to me several times. But I was in the right place at the right time with the right team, and we were able to expeditiously deliver that baby and get mom and baby safely. She was able to be discharged home 3 days later. But to some, that experience can be traumatizing as a physician. And so that is piece of the puzzle, part of the puzzle too, as to why physicians may step back and say, this is not an opportunity. This is not something that I offer my patients because I've been in a situation. And I know it should be individualized, et cetera, but sometimes those traumatic experiences really do linger. So I do have to acknowledge that as well. But what can we do to improve and get VBACs back on the table, essentially? No pun intended there. So again, the availability of 24-hour anesthesia is very important. And I think some of our hospitals do have that. They may not have dedicated anesthesia for 24 hours, but I think that's a part of the puzzle is to see if that could be implemented. And a lot of hospitals locally have actually been implementing OB hospitalists who provide in-house coverage, right? They are there to be present, to assess, and to help the community obstetricians in the event of an emergency. If they're not readily available, that they step in. They are board certified, trained obstetricians who can step in an emergent situation. Also, getting the hospital administrators, like I say, those with the ability to make that type of change, have them changing their hospital policies and empowering physicians and nurses to encourage VBAC amongst the patients. I think that can also help improve the success and the conversation about VBACs. And wouldn't it be nice if the insurance companies would say, let's reimburse more for the VBAC than the C-section? Because certainly, again, that's part of the piece of the puzzle, is perhaps the risk that is being taken on should be valued more. And so that's certainly something that should be considered, but insurance is always a challenge these days. Well, let's look at the VBAC rates after cesarean by race and Hispanic origin of the mother. And this is actually data between 2016 to 2018. And here you see the trends here. If you look at Black women and Asians, we have the lowest percentage of rates of VBAC, but it's slightly increasing. So amongst Black women, we went from 12.4% in 2016, and we're now up to 13% in 2018. Native Hawaiian and other Pacific Islander, they're beating us, I guess. They're, but I think when we look at this globally, what's important to see here is that there is a slight increase and a slight pickup in the number and the rates of VBACs across the country. And here we can look at it again, the change in rates of VBAC by state. And again, there's been a significant increase. Yay, Florida. The dark blue states are those states that have had some increase and improvement in their rates over the last, from 2016 to 2018. This is the most recent data available to me. I would avoid Wisconsin. It's the only green state here on the map. So having this background, having this information, having this knowledge, the question always lies in, how can we improve this? How can we lower the C-section rate? And as I started this conversation, it's been a question that's been asked year after year after year after year. And although I'm always hopeful, I think the question then lies in, well, if we can't lower the rate immediately, how can we guide our patients? How can we as clinicians and physicians help our patients and the community at large? And what I have come up with here is just a checklist of things that I think patients can use to help make sure that they get the care that they want. And I think education is really important, especially in our community. It's important that, patients, they talk to friends and family. Who was your doctor? What was the discussions like? What were your visits like? Having a medical advocate. I love when my patients have a guest or a family member here who knows to ask the question that they may not be even thinking about because they're overwhelmed, they're stressed. This is a new experience. This is an overwhelming experience. And so grandma might be there, or cousin or sister. Hey, doc, what about this? What about that? So having a medical advocate, I really do encourage my moms to find someone to help support you, not just taking care of the baby when the baby's born, but taking care of you during the process as well. It's okay to interview your doctors. It is. Ask the right questions. Meet the doctor. And I know in these days and times, I have a surprise pregnancy, so you may not have time to interview the doctor. But I also want to encourage patients not to delay going to see a physician once they find out they're pregnant. And after that first visit with the physician, if you don't feel comfortable with that provider, it's okay to change. We actually don't take offense. It's a relationship, a doctor-patient relationship. And if it doesn't meet your needs, it's okay. Truly, we want the best for you during your pregnancy. This is a very exciting time for our patients. And so if we are not the right one for you, then we certainly will help you find another provider. because we really are colleagues at the end of the day. So interview your doctors, ask them questions, bring your notebook, bring your friend. Research the doctor's C-section rates. And I know depending on what state you are and what hospital, some are more public than others. And sometimes the doctors may know their C-section rates. Now, whether they'll be open about it, I don't know, but it's okay to ask, hey doc, what would you say your C-section rate, looks like? Do you think you do more or less? What, on average, it's okay to ask that question. Now, using alternative options to communicate with your doctor, I want to encourage this because there's more being asked of us as physicians these days, and we don't ever want our patients to feel that we're not present for them or willing to give them the time to sit down to answer all of their questions. But if everyone's doing the same thing in an 8-hour day, that certainly does lead to some challenges. But we often try to do our best. And so what I do encourage patients to do is to also use those alternative methods of communicating with your doctor. We have these electronic medical record systems now that allow patients to send messages, a quick question to the doctor. And it's like texting or emailing in a safe way that's compliant with all the privacy regulations that will allow your doctor to kind of be able to get back in touch with you and give you those answers that you might need. So I encourage you to not just, use the method of sitting face to face, but also after you've met them face to face, you've asked them a few questions, something might come up later on. Don't shy away from sending a message on the patient portal. Don't be mad that we can't get to the phone right away to answer that question. That the patient portal or other means of communication really does help a lot. The other thing I would encourage is for women to seek routine medical care even prior to pregnancy to optimize their health. Don't just wait for the surprise pregnancy test. Follow up with your primary care provider. If you have diabetes, if you have high blood pressure, cholesterol issues, if you have that chest pain that comes and goes once in a while, or you feel like your heart's beating fast or fluttering, could it be a thyroid problem? Like, follow up because you want to make sure that you're in good health. Not waiting until you're pregnant. Diet modification and exercise is always going to be of value, not just before pregnancy, but during pregnancy and after pregnancy. And everyone always asks me, doc, I'm pregnant, I'm going to exercise. Is that okay? And I say, yes, of course, but in moderation, of course, especially for those women who weren't exercising before pregnancy. There are women who want to start doing Orange Theory because they don't want to gain weight during pregnancy. And I say, wait. If you weren't already physically fit for that, I don't want you starting that now. But moderate exercise, low impact, walking for 30 minutes, an elliptical, low impact, certainly goes a long way, along with nutritional choices. Being compliant with care is also so vital in caring for our women. Lots of ladies, in fact, the patient probably before this visit hasn't followed up. She says, I haven't seen my primary care for my kidneys in, several months. And, it's really important that we take care of ourselves and that we are compliant with the care that's provided to us. And again, if you're not happy with the care or if you have other questions, seek an alternative. That's okay. Another resource that I think we don't utilize as often is that our insurance companies are providing us with case management services. They'll call and check on you, especially when you're pregnant. And so don't hesitate to reach out to your insurance company, or if someone calls to check in on you, yeah, that's actually a positive. We want to make sure that we optimize your outcomes. Sometimes the insurance company, actually, there is a patient I have who, before the patient even saw me, they recognized that this patient had diabetes, and then the insurance company actually reached out to me to say, this is a patient that we can help you with and help you manage X, Y, and Z, and these are some of the offerings. And it was through the insurance company. So again, there are lots of tools that they're providing patients nowadays, because our goal at the end of the day is to improve not only the maternal health, but the neonatal health. So this conversation has to be balanced, right? It's not just about what the patients can do. It's also about what we as providers, the other part of the equation, as the physician, what can we do to make this better as well? Educating our patients. Again, it's all about education. Pamphlets, literature, social media is another avenue. Using data, and I hope that my nerdy moments in the initial stage of this presentation, I use data to help inform my patients of, look, there was this ARRIVE trial and this is what they found. And do I think your risk is going to be increased if you're going to be induced at 39 weeks? No, because of the findings of the study. And also because of this, this is why I'm recommending a delivery, et cetera. And I go through the process. So using data to counsel your patients and informing them how to better, what to expect and how to go through this pregnancy and also the delivery. Offering preconception counseling, that always allows us to identify pregnancy risks in advance and create an action plan. And I see several patients who come to see me for preconception counseling, and we create a game plan, for the next pregnancy, we need to do this and this and this, and let's look out for this, start doing this now. And, that's something that I think is of benefit to those women who seek preconception care. Informing our patients of our delivery methodology, right? We each have a different style when it comes to delivering patients. I know I had a style when I did my deliveries back when, and providing patients with the pros and cons of this induction or C-section. Well, how do I induce? What are the medications that I use to induce labor? Mechanical versus medical drugs that we may use. And I try to individualize the care. And again, that shared decision making. Patients actually have the right to decline and to defer. And I always tell patients that I'm not here to force you. I'm here to educate you and let you know what the choices are and the pros and cons of each. There's this thing called patient autonomy. And so even after I counsel you that, yes, you should be delivered at 39 weeks, if the patient says no, I will continue to bring it up, but I'm not going to force someone to do something that they don't feel comfortable with. And so I just continue to educate and allow the patient to be a part of the decision making. The only reason that I may part from that are in circumstances where there is severe concerns for her well-being and that of the fetus. So I do have to take that into consideration as well. Now, the annual pap smear exam, I think we need to use those exams wisely. It's not just about the pap smear anymore and the breast exam, right? We need to use that annual exam as a way to start highlighting other issues, right? That preconception visit, so to speak, can be, okay, did you know that you're at risk if you were to get pregnant? You're a woman of color, you have a BMI of 32. Let's start working on our nutrition and our exercise. And if you were to get pregnant, baby aspirin has been shown to reduce your risk of preeclampsia, et cetera, et cetera. So using that time to just bring up, even if it's a small topic, something, a snippet, a little window of opportunity to educate the patients about what are we doing now with pregnancies and how can we optimize and ensure a good outcome for both her and her future child. And with that, I thank you for paying attention and listening, and I will plug my hole up again so that no ruptured membranes there. But I really appreciate the opportunity to give you my perspective on the cesarean birth rates. And I hope that you all have found value in that, and I'm available for any questions you might have. Thank you.
Thank you so much, Dr. Davidson. Amazing presentation, a lot of information, and we already have some questions that are brewing. They've been putting them in as you've been going. So is there an easy way for a person to find out your doctor's C-section rate, or is it only by asking the doctor?
So there are some hospitals that do publish that data online. If they do not publish it online, I certainly think you can call the hospital and try to speak with the medical staff office and say, look, I'm pregnant. I'm trying to find a physician to deliver me. And I understand that this doctor may be on staff at your hospital. And I'm trying to find out if you are all monitoring the doctor's C-section rate, because that's important to me. And I would like to know if that's information that you can provide me about this provider.
Okay, and then I have, if most OBs are not doing VBAC, won't the C-section rate remain high due to second pregnancies and deliveries of women that had a C-section for the first pregnancy?
Mm-hmm. Yes, it certainly will continue to rise. The World Health Organization is hoping that the number will decrease to maybe 24%, but it has remained persistently at 30 to 33%. It hasn't changed in the last couple years, so hopefully it will be stable, but there are talks that this will just continue to increase and increase over time. And it's quite unfortunate, but you're right. And I think, again, going back to administration and hospitals now being open to having OB hospitalists, that maybe this conversation can actually change. Maybe having that availability of hospitalists in the hospital covering the doctors too, that will allow them to say, you know, this is a patient who is a candidate for a VBAC. Why not try?
Okay. All right, are there any other questions right now that we have for Dr. Davidson? And while we wait, I guess I have a question of my own. I'm just curious. I know we talked about women who are 39 weeks and, you know, there's possible risk. So just saying, instead of waiting until you're 40 or 41 to get induced, what about the women who aren't deemed medically necessary? How do we go about trying to get them to wait to do more of an active labor? Because we know, when looking at some data, we see that with first-time moms who are basically, I don't know if there's a way to tell if they're deemed medically necessary or not, but when they get induced, a lot of them result into an emergency C-section. So is there a way to educate them on waiting it out if they're not deemed medically necessary?
Right. So are you saying that these women, these first-time moms, are asking to be delivered at 39 weeks? Or
they're asking to be induced, right? Because they're tired, they're like, you know, they're over being pregnant, they want the baby out, their feet are swollen, they're like, we're done, right? I just don't want to do this anymore. Can I get induced at 39 weeks? And there's no risk associated, or so far, you know, with the pregnancy.
Yeah, actually, yeah, I do come across that from time to time as well. And I just try to, you know, educate them again and say, look, there is everything right now continues to be normal. I know you're tired, but your little one is still developing the brain, still developing the lungs. And, you know, there's a small risk, you know, that your baby could have a little respiratory distress when it's born. And I want this little one to come out and be able to bond with you right away. I don't want this little one to be taken off to the NICU. So, you know, I know it's painful for you right now to continue on. You're so close, but I think waiting it out a little bit will certainly have its benefits towards the end. So I try to not make it seem like I'm forcing them to do. Again, autonomy is there, but I also try to be lighthearted about it. And I say, doesn't your baby deserve the best? You've made it this far, right? Why not just hang in there a little bit longer? This will only benefit your baby. Everything looks great. Your blood pressures are normal. You've gained the appropriate weight. The baby's weight is also normal. Amniotic fluid, everything looks great. And then I'll offer them the option. I said, I'll keep an eye on your little pumpkin. You know, and if I see anything that triggers our need to deliver you sooner, then we will. But I think right now we can continue the course and let nature be really take over and take a part of this. And I do mention that if they do deliver by C-section, that all their future deliveries will have to be by C-section because of what I know in the local area with the area hospitals. And I think sometimes that's where they say, oh, I didn't know that. So again, that education piece of informing the patients, because they have no idea until the next pregnancy. Oh, my doctor said I have to have a C-section. I wish I had known. I don't know if that answers your question, but.
Well, yes, it did. It does just bring some more clarity. I feel like a lot of, you know, we think about it. I had a conversation with my cousin and my aunt. She was pregnant and she's at 39 weeks and I want to get induced. I'm just tired. I just want to get the baby out. And I'm saying, you know, if you get induced, there's a good chance that it may result into a C-section because, you know, you had a clear pregnancy the whole time, but it was just because she just was over it. She didn't want to be pregnant anymore. And her mom says, no, I mean, she'll be fine. She talked to the doctors, getting induced will be fine. And I said, okay. And then I get the call, you know, that they induced her, and then 12 hours later, like, oh, she got the epidural, and then another 12 hours later, oh, Makai is in distress. They're going to have to give an emergency C-section, you know? So I just think more education around that piece is at 39 weeks, if there's no risk associated with the pregnancy, to just kind of like, you know, let the pregnancy take its course. Right. Because, you know, like I said, data has shown when we went back to view it that moms that are getting induced, you know, have a good chance of it resulting or ending in an emergency C-section. So
again, it can happen. The ARRIVE trial shows similar rates, but it's not that it's zero. It can happen. The other piece of the puzzle that I use to guide my patients, especially when I did deliveries, I would check their cervix. I would make an assessment, is your cervix favorable for an induction? Because if your cervix is closed and the cervix is posterior and not even in position or ready for anything, I'll say, yeah, you'd probably be being induced for several days here. Why don't we just give it another week and we'll reassess? So I try to encourage my patients and, guide the conversation that way so that they understand it's best if we're going to induce you, it's best when it's set, the stage is set essentially for a good outcome and to reduce the risk of a C-section. That Bishop score that, that we use in healthcare quite a bit in obstetrics, I'll show her, I'll say, look, this is your Bishop score. This is how I calculated it. Your cervix is closed and posterior. There's no dilation here. So let's just kind of wait a little bit. So you're right. I mean, education is really the piece so that patients will kind of say, all right, I'm doing it for the baby,
Right. All right, so we have something else from Teresa. Are there additional benefits of vaginal birth in regards to baby's exposure to mom's microbiota in the vaginal channel?
Yeah. There have definitely been data supporting that the natural environment from a vaginal birth and the microbiota, the natural healthy bacteria that lives in the vaginal canal actually has been healthy and beneficial for the fetus. Especially in intestinal health and so forth. In fact, there are even people that say, oh, for those babies who have C-sections, they've come up with all these things to give the baby, part of the vaginal flora. I'm like, what are you doing? But there have been shown to be a benefit for vaginal birth for that reason, for the fetal in the newborn gut health and so forth.
Okay, and Martha is asking why the mom with a history of a C-section has to have a C-section with the new pregnancy.
So the risk of that uterine rupture, like I mentioned, and like I said, I had my own experience where, the patient was in labor and that scar under the pressure of the contractions, that scar can open up and the baby can go through that scar and end up floating in the abdominal cavity. And that's an emergency like no other. And so because of that risk, and it's known to be approximately 1%, because of that risk, some doctors will say to a mom, look, there's a risk of this uterine rupture, and that's why you need another C-section with the second pregnancy and subsequent. And that number slightly increases with the number of C-sections. That's why even after the second C-section, many physicians will hesitate and say, this has to be a C-section again. There's only a few doctors who would allow a patient to have a vaginal birth after 2 C-sections. But that is the reason why, because of the risk of uterine rupture.
Okay, well, there is no other questions. Dr. Davidson, thank you so much for doing this and being here today and
You're
putting
welcome.
this together. We really, really appreciate it. The information was very vital and key. And I hope everyone that's on this webinar today is taking some of these pieces and is figuring out how we can relate this to these moms that we're working so closely with to improve birth outcomes and to make sure we have healthy moms, healthy pregnancies, and healthy babies. So every time somebody slides something in here, says, just a comment that says, thanks, doctor, the microbiome support for the breast/chest feeding. I don't know if that's a question or just a comment, but
oh, okay.
Okay, yep, and just a whole bunch of thank you. So again, thank you so much for your time. We appreciate you being here and doing this for us.
You're welcome.
Thank you for participating in our second annual Black Maternal Health Week workshop webinar. And then I guess it's so long until next time.
Happy to be here. Happy to provide the information. You know how to reach me.
Yes, I know how to reach you now. So I will be coming by.
All right.
Thank you so much.
All right. Bye-bye.
All right, so okay, folks, so now that we are winding down, let me try to get this back up. We'll do this here. All right, so we're winding down and coming to a close. So again, I just want to thank all the presenters that we had today. Esther Mccann, founder and CEO of Metro Mommy Agency, Elizabeth Simmons and Briana Betton from the Doula Network, as well as MeCant-Founder from Count the Kicks and Healthy Birthday. And again, thank you to Dr. Sasha Davidson for being here as well. I hope all this information was very vital and help us to be able to better assist these families that we are serving here in Broward County. And again, you know, remember that Black maternal health is a shared responsibility. So it's not just up to the doctor, it's not just up to the mom, it's all of our responsibility. It's everyone that is on this webinar today and beyond, and we want to make sure that we are all delivering this message universally together, the same messages, and hoping that everyone that we're being able to impact these moms and these families by giving them this great information and being a support for them. Again, so as they say, or as that's the new theme this year for Black Maternal Health Week, is act now and do your part. So please do that. So thank you again to everyone. Thank you to everyone in the chat. We're going to end this a little early today, but I do appreciate you all for being on today. And until next year, so long.